pond5.com. 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 pond5.com.
Muscle energy, lumbar, spine, sacrum, and pelvis. Very important area involved in all kinds of movements. When patients have trouble here, they have pain frequently, they have balance issues, they have musculoskeletal dysfunction, and that's what we're going to identify. What are the biomechanics of the lumbar, spine, SI joint, and pelvis? How do those biomechanics become disrupted? Maybe somebody fell off a horse. Maybe somebody's an ice skater, landed on their butt. Another person, football player, got involved in a tackle by, 6 people. Issues happen. How about car accidents? So many people getting into car accidents. These traumas tend to move things out of their normal symmetrical positions. How about people's work or play activities? How many people are right-handed? 85% or so of the population. Okay? So are we doing things symmetrically in everyday life? Lefties going this way. Some of this leads to the asymmetry. Now, I've never come across anyone who is perfectly symmetrical. Have you? Has anyone seen anyone perfectly symmetrical? No. So we're going to look and see, can we at least get the symmetry as close to neutral as possible to balance the forces about the body so that we don't have to compensate so much. Now, my background, my name is Teresa Schmidt. I'm a physical therapist. I'm board certified in orthopedic physical therapy. I'm also a licensed massage therapist in New York State. I've been a PT for 27 years, and I love it. I do a lot of manual therapy, have a private practice, Flex Physical Therapy, where I use these techniques on a regular basis with my patients, and I could see the difference. I've also been in 13 car accidents. Anyone ever been a patient on the table? Okay, a couple of us, you know what it's like to be on the other side. So I've been there frequently enough to see that certain techniques actually work. It's one of the reasons I teach them. Like, yeah, that worked for me. Okay, good, let's try it. But sometimes we need multiple interventions. So today's interventions are very good if you see those very specific asymmetries that we talk about, if you see those specific joint dysfunctions we talk about, but bear in mind other interventions may be necessary. Exercise programs, manipulation, home programs, ergonomics, sports and everyday training re-education, right? Neuromuscular re-education. This is a component of your whole treatment plan. If your patients come in and they're in so much spasm or pain and you see, gee, it looks like they have a dysfunction, maybe they're in too much pain to treat right away. Maybe you might need some modalities or some other manual therapy to relax them or even some medication first. So again, we're using this as part of the plan. Today, bear in mind, we're looking solely at muscle energy intervention. I did, however, sneak a little bit in the back of your book on myofascial work because I found that using muscle energy alone, unless someone has a more acute problem, typically doesn't hold very well unless you add the soft tissue component. That muscle's tight, it's in a contracture, there's fascial restriction. That has to be addressed as well. Doing a simple contraction that we do in muscle energy, in my opinion, is typically not enough. So we'll add some of those components. You'll see a little bit of that at the end of the seminar. Muscle energy. I'm using the traditional definition of muscle energy. This comes from Dr. Phil Greenman, who wrote the book Principles of Manual Medicine, which frankly, when using that book as a resource for muscle energy learning as well as teaching, I found it was next to impossible. Maybe it's just my brain, but so you too, you've seen that. So it's a little bit difficult. I'm going to take a little more simple approach, but I like his definition. Okay, it's manual medicine treatment technique involving voluntary contraction. So there's your first hint. If the patient can't give you a voluntary contraction, this is not for them. Okay, and we're going to be doing this in a very precise way. So as he says here, precisely controlled direction at varying levels of intensity. Back when I went to PT school, they told us, push on that patient, don't be a lazy PT, have them push against you as hard as they can. And what was the first name I got in my first clinic? Veterans Administration, downtown Manhattan. The bone crusher, you the bone crusher. Second day I walked into work with my little white coat, right? You the bone crusher. The vets are hiding under their pillows. It's like worse than going to war back then when you saw me. Because I didn't understand the varying levels of intensity. You're going to find you can use some very light contractions, from ounces to like a pound for most of these. So not a lot of effort is required on the part of the patient, which means they're going to be less sore. And guess what? It saves your hands as well. So we're going to use lighter contractions. I can show you places in the literature that says if you don't use exactly 15 pounds of force, this doesn't work. Another person will say 1 pound. Another person will say ounces. Judge how your patient is. Are you working with an elderly, debilitated person, or are you working with a football linebacker? You're going to use a different amount of contractions. So gentle contractions generally work. If you're not seeing that kick in, you could have them use slightly more force. If it's still not working, hey, try something else, right? It might not be the only thing that works. Against a distinctly executed, again, the language. How many of us get out of school, you start working on patients, you know you saw something once in class, oh, I think she put her hands here and here, and we get sloppy. How many of you have been to the clinic and see the guy doing his exercises? He's got his weights in his hand, you've seen him too? Yeah, so what's wrong with that picture? It's not very distinctly executed, not too precise, and why does he have weights in his hands? Right? So you see that if someone's compensating, they're not doing the right thing. He's going to hurt his neck. This is obviously someone with a shoulder problem, using too much upper traps instead of, say, the supraspinatus. So you want to make things more efficient. You want to make it more precise. I'm hoping to bring across a little bit of that to you today. Where you place your hands is going to decide where that patient contracts, what level they move, where they push, and how they correct. And if we're sloppy, you're not going to get the good results. So practice really helps make perfect here. Okay. What's backing this up? Neurophysiology. What we're doing here today is based on reflexes. And there's traditional views of reflexes in the literature. I'm giving you the traditional view. I have seen also new research saying that all our views on reflexes are completely incorrect. Well, they still work for me on the patient, so I don't really care why they work. They work on the patient. Now they say, oh, there's no such thing as reciprocal inhibition. Well, there's no such thing as autogenic inhibition. I have other research will show you with EMG studies that there is, and another EMG study will say there isn't. So I'm just getting that out of the way first because somebody's going to say, I read a study that said, that's fine. If it's working on my treatment table in the clinic and I'm getting a functional result, fine. I'm going to read the studies, but I'm probably going to find something strange about how they did that study, right? These are things you're familiar with. What are the proprioceptors? Reflexes determine how our patients move. So we're going to look at the reflexes of the proprioceptors that allow people to have functional movement. If those reflexes become upset by disease processes, abnormal stress to the body, some kind of damage, trauma, there's going to be aberrations in the reflexes. Too much sensitivity to movement, or in some cases too much inhibition, too little sensitivity to movement. And you'll see movement patterns are altered out of the normal sequence. That's what we're going to be looking here. We want to restore normal biomechanics across the joints. So we know that you learned from kinesiology, muscles have to contract with adequate force for functional activities. If you have the muscle length tension relationship, remember learning about that? Muscles have to be in a certain length to contract with adequate force. Usually at or near their resting length or slightly longer. If a muscle's too bunched up, too contracted, it's not going to be able to contract well. It's not going to be strong. How about its antagonist on the other side of the joint? That will also be weak. So you'll see weakness if you have an imbalance across the joint. You'll see functional deficits coming in. We want to restore normalcy to the reflexes, restore the normal length tension relationship of muscles as they surround a joint, and see the person also as a whole picture. Today we're looking primarily at joints to be precise and specific, but recognize the joints are part of a kinetic chain, right? Everything's connected in the body. That person coming in, oh, my SI joint, it hurts over here, typically might also have a problem with their TMJ. And if you're familiar with craniosacral therapy, you'll see their sphenoid is off in the same exact direction as the sacrum. So everything's connected. Of course, when we deal with insurance, who takes insurance? Just about everybody, right? So you're dealing with managed care, I like to call it mismanaged care. Did they let you look at the whole body? How about workers' comp? Workers' comp patient comes in. Oh, I hurt my back. So workers' comp says we're only covering the back. So when I find that this person fell 2 stories off a ladder, they're a contractor, they hurt the back and the shoulder, but the orthopedist in all his wisdom only wrote down the back issue. Now the guy's like, oh, I can't lift my arm and it makes my back hurt to try to lift my arm. Why is that? So I do a nice lat release, I do some shoulder release, the back feels better. Does comp pay me for that? No. I get the refusal. We ain't paying for this, no. Treat the person, not the body part. Okay, so reflexes control muscle function. Your monosynaptic reflexes, your proprioceptive reflexes, your muscle spindle, right? Tap the muscle, what happens? You get a contraction. So a quick stretch gives you a contraction. That's the muscle spindle. It's one of our sensory receptors. Let's take a look. When muscle spindles become irritated by stress, disease, or injury, they become hypersensitive to movement. We would say their spindle bias is elevated. Too much sensitivity to movement. You remember the muscle spindle, the muscle gets a stretch, sends a message to the 1A afferents to the spinal cord tells the alpha motor neuron, contract that muscle, protect yourself from being torn. And that comes in very handy to protect the body. But if those muscle spindles are firing excessively, the muscle keeps firing, contracting, and it's maintaining tension. The patient tells you, I feel tight, I feel sore. Make a fist, tight. Go ahead, make a good hard fist. Open it up at lunch and tell me how that works for you. Right? That's what they're doing. Their muscle spindles are not letting go because they have too much spindle bias. Excess firing of the spindle, making things tight. And that's basically what we're talking about here. Spindle bias. We're going to try to correct that using reflexes. Autogenic inhibition, reciprocal inhibition, etc. Post-isometric relaxation. So those spindles get set to what we call high gain, high sensitivity. It tells the muscle it's being stretched even when the person's not moving. There's a person who says, you know, I feel so tight, they're not even moving. When we measure tight, what do we use? A goniometer, a flexibility test, a tape measure. It means something's not moving enough. They're not even moving. How could they be tight? Because they sense that muscle contraction. And it gets sore because they start using up oxygen. That persistent muscle contraction creates what we call a local, okay, or a segmental facilitated reflex. It's just a background of how this muscle energy works. Local reflex. Say I decided, oh, shotgun wedding, I have to go to a wedding in 2 weeks, I just found out about it today. I have to wear a gown and I gained 15 pounds and that gown I wore 10 years ago is not going to fit. So what do I do to make sure I fit in that gown in the next 2 weeks? Diet, right? Diet and exercise. Duct tape on the mouth first, stop eating, and then exercise. So I'm exercising and what do I feel the next day because I went nuts in the gym? Sore. I feel a local facilitated reflex. Trigger points in the muscles I overused. Can I stretch out that muscle well the next day after overdoing it? No, because the muscle spindles are firing saying, hey, idiot, be careful. Okay? Protect yourself. So muscle spindle bias, local facilitated reflex, trigger points, abnormal tension, you can measure that with a goniometer. Pain, you can measure that with a pain scale. 0 to 10, how bad does that hurt? Oh, that's about an 8 today. Okay, so this is what we're looking at. These are things we can actually measure. Okay, segmental facilitated reflex. What if I decided I'm going to fit into that gown by hook or by crook? So I just keep going. Now there'll be so much painful afferent impulses into the nervous system that it overloads. And the area of the spinal cord where those pain impulses went in start to overflow into other segments of the spinal cord. So say I'm doing biceps, like C5. Now you're overflowing pain impulses, okay, cytokines, neurotransmitters into C4, C3, C6, C7. You're getting a segmental facilitated reflexes. Now muscles and the sympathetic nervous system innervated at all those levels becomes hyperexcited. Now you see a decrease of circulation, right? We said sympathetic nervous system. What does that do? Vasoconstriction. Does the body like when you cut off its blood supply? It's not a fan, is it? Right? So you'll get more pain as a result of that, more spasm, and you see people locked in these cycles. An extreme example of that segmental reflex would be reflex sympathetic dystrophy. It used to be called pseudex atrophy, and now what did they change the name to now just to mess us up? Complex regional pain syndrome. That's an example of that overflow into the sympathetic system, creating excessive pain, problems with the muscles, problems with the biomechanics. So just to give you an example of what reflexes back this up. What are indications for muscle energy? Something's too tight, something's too loose. You see a biomechanical fault across the joint. Typically, agonist may be too tight, limiting the motion, antagonist too inhibited and weak. You see a biomechanical fault. So different reasons to do this. Contraindications, the usual contraindications to movement and muscle contraction. Something is still in the healing phase, an unhealed fracture, a wound that's still healing, scar tissue that's still healing, maybe there's sutures there. Okay? If there's any contraindication to movement, we're not ready for muscle energy. If there's any contraindication to active muscle contraction or stretching, contraindicated to muscle energy. How do you know? You get medical clearance. I could have 3 different patients come in with a so-called rotator cuff repair of the shoulder, and I'm going to hear 3 different protocols from those 3 surgeons. So I better find out one guy, oh, you can't go past 45 degrees of external rotation for the next 6 weeks on that guy. Okay, fine, let's avoid that. But I'll have another person that their orthopedist will let them do that in 4 weeks. Maybe they're younger, they did a little different style of rotator cuff repair, what have you. So I'm going to check with their surgeon first to make sure, are they cleared for movement? Are they cleared for contraction? Great, we're good to go. Okay. Bear in mind that we are using contraction, so sometimes people get a little sore the next day. If they're not used to contracting that muscle and now they're doing something they haven't done in many moons, they might be a little sore. So I always let the patients know, informed consent. Muscle energy is basically a form of an exercise. And it's exercise done to re-educate abnormal reflexes that are interfering with their daily function. That's the basis of it. I don't care if you call it muscle energy, PNF, ART, AIS. There's like 20 new names for all the same stuff that has been around since the 1950s. In the evidence-based literature, however, use the terms muscle energy technique to look up this work to see where it's actually reflected. Different contraction types, of course, you know these isometrics. Muscles contracting, the joint is not moving. The muscle's moving, but the joint is not moving. Okay? That's usually the simplest form of contraction, easy to start with. We'll use a lot of isometrics today to get a post-isometric relaxation effect before we start stretching a muscle. How about concentric, the muscle's shortening? Okay, argent insertion or approximating, next level of difficulty. How about our eccentrics or isolytic? Eccentrics are a lengthening contraction. We call that isolytic muscle energy because it's a nice way to break down some of the contracture, to break down some of the fibrosis when someone has that short a muscle that is actually in a contracture. Which ones might make them more sore tomorrow? Any ideas? Usually eccentrics. That's pretty well reflected in the literature, but again, if you go back to the literature, I taught at the Fascia Research Congress this year in Vancouver, and they had a whole body of research showing that eccentrics actually is less painful than concentrics or isometrics. So there it is. There's all kinds of things out there in the literature. Survey a lot of studies. Most of the studies show that the eccentric makes you a little more sore, but also builds up your strength a little quicker. Okay, there's Sachi. That's my baby. All right, muscle energy therapy. What is the role of muscle energy? To manage what we call somatic dysfunction. These terms come from osteopathic medicine. My background training is from training with osteopaths, particularly from New York College of Osteopathic Medicine, the DiGiovanna group. Very good. And most of what we're doing today is based on the Fred Mitchell technique. Fred Mitchell Sr., Michigan State University, started writing about a lot of this work back in the 1950s. His son Fred Mitchell Jr. is continuing in the work, and many people have also picked up on it since then. So our outcomes, again, restoring the normal length-tension relationship as muscles as they surround the joint, because typically if you're having a problem with that, you have a problem with either contractility or flexibility, and you have enough problems with that, you have issues of function. So again, I highly recommend measure your functional outcomes pre and post-treatment. Some of the functional outcomes are things you can only measure after a patient has gone and tried some functional activities of daily living. So I might give them an Oswestry Back Disability Index when they first come to therapy. Try some interventions. Maybe I see them a day or two in a week. A week later, let's give them the Oswestry questionnaire again. Has it changed? Okay, because again, the literature doesn't necessarily back up everything we're doing here today in terms of our accuracy of palpation. Precisely, but my functional outcomes will back up what I'm doing in the clinic. Okay, so technique, this is just a little different view of muscle energy technique. This is from Dr. Leon Chaitow. We're going to use this this morning when we work on some lower leg things that relate to the pelvis and the back, so looking at the hip, knee, ankle. He says you have 2 stages for muscle energy, and he combines muscle energy, PNF, as being pretty much one and the same thing. They're just techniques using reflexes to trick the body into doing what we want it to do, right? That's all it is. It just has a fancy name. It's just using reflexes. He says, okay, you have the acute stage, you have the chronic stage. This is from his book, Muscle Energy Techniques, Dr. Leon Chaitow. Acute stage, what happens? Say somebody's stiff. You want to increase the range of motion. You're going to resist the muscle that's short and tight where? At the first barrier. Now this is what he does. I don't necessarily do the same thing. You do whatever you think is appropriate in the clinic, but just showing you what's out there in the literature. So say you have an elbow flexion contracture, a guy had a fractured dislocation of the elbow, cast is off, fracture's healed, and the orthopedist says, yeah, get that moving, okay? So it's like, oh, I can't straighten out. I can bend some, but I can't straighten out. So thinking, okay, the elbow flexors are short and tight. We measured with our goniometer. So we're going to contract the flexors, hold them. He says to hold it 7 to 10 seconds. New York College of Osteopathic Medicine, most of the osteopathic literature, New York Minute, we're in a hurry, 2-3 seconds works just fine. I look at a book I have right over here by Dr. Sharon Weiselfish. He says you're holding it like 6 to 10 seconds. I'm holding it enough that I feel the patient contract. Some patients are a little slow on the get-go, right, to get a contraction going. Some people immediately respond. So I make it according to what the patient's abilities are. Usually 2-3 second contraction works just fine. Hold it, hold it, hold it, relax. As they relax, after they relax, don't start cranking on them until they let go. Then we stretch it, right? Some people call that contract, relax, PNF, or now they call it post-isometric relaxation. I was reading the massage literature. I'm a massage therapist, and it says, oh, we have a new technique, post-isometric relaxation. It's the same thing they wrote about in 1950. Okay, so it's just sold in a new package so you can buy it in a seminar. All right, so this is what happens. We're holding that contraction 2-3 seconds or up to 10 seconds. Why does it work is really the question. They did some EMG studies, electromyograms, remember that? They stick the needles in the muscle. You see a normal electrical pattern of the muscle or an abnormal pattern. Typical abnormal pattern, trigger points, tight muscles, too much contraction, too much activation. And what happens here is after an isometric contraction, there's a latency period that's been measured, 15 to 30 seconds, within which the muscle can't contract hard against you again. It's the perfect window of opportunity. Get in and stretch this guy. And that's one of the reasons that post-isometric relaxation or contract relax works. We can see the relaxation known as a latency period. It's the same as a refractory period you might have learned about in exercise physiology. They can't fight you, so you might as well get in there and stretch them. Good timing. How long do you hold a stretch? Or just yell it out? How long do you guys typically hold a stretch for somebody? You want to increase range of motion. 30 seconds, how about 5 seconds? Anyone for 2 seconds? Anyone for 20 minutes? It's all out there in the literature. I downloaded literally 1,000 studies. And I read all the abstracts. It took me a month. And I actually read some of the full studies. They're all crazy. Most of them that are well done in terms of the evidence-based literature, 15 to 30 seconds, which interestingly enough matches the latency period. So something to think about. Chronic stages. Now Dr. Chaitow says, okay, say it's 2 weeks later and my guy with the elbow flexion contraction, he's moving better. It's like, I can't quite straighten it out all the way. So we might say this is the chronic phase. What do we have here? Oh, maybe it's minus 15 degrees of extension. Chaitow says, well, put them right at the barrier. Okay. Sometimes another group will say put them at the mid-range. I always put the person at the barrier. What's the barrier? The limitation of range of motion. That's as far as I could go. Can't you push them a little past there into the passive range barrier? That's where I'm going. And always within the tolerance of the patient. So right at the barrier, contract, hold it again. Now he's holding it. Sometimes he says 10 to 12 seconds. I'm holding it 2 or 3 seconds. It works just fine. You do 5 reps of this followed by a stretch. You can measure an increase in range of motion. Have the goniometer ready. Look at the difference. So post-isometric relaxation is what it's often referred to. Here's my reference, Di Giovanna. 2 to 10 second hold is most well reflected in literature, works quite well. Precautions, don't be the bone crusher. Right? Don't start cranking on the patient before they let go. You ever tell a patient relax? And like, relax. I am relaxed. No, you're not. Put that, oh, okay. They don't even know they're holding. And like I said, I've been a patient on a lot of tables before. So many people start cranking before I let go. And I'm pretty quick on the let go. You have to pay attention. Feel with your hands what's happening with the patient. How about if their eyeballs are bulging out of their head? Should you keep progressing? No, he'd be the bone crusher. So always within the tolerance of the patient. If they can't tolerate what you're doing, maybe they need to have modality to lower the pain sensitivity. Maybe they need to have some medication. Oh, your orthopedist gave you some Vicodin. Great, take that an hour before you come here. And make sure someone else drives you. I don't want you hitting my car in the parking lot. So these are the things you have to look for. Sometimes someone is so sensitive, maybe like right after a shoulder surgery. Oh, I had an acromionectomy yesterday. Doesn't that orthopedist want you to move that thing today? Does the patient want you to move it? No, they're not happy. So take that Vicodin. Yeah, that's a time when I'm going to put electrotherapy. Vicodin, I might need a Vicodin, right, to deal with it. I put electrotherapy on the patient with ice to numb them out. And while that's on and they're nice and numb, that's how I start moving them. Because the orthopedist said, if I don't move them, I'm going to kill you. You're going to mess up my surgery. Move them whether they like it or not. So sometimes the movement hurts, but we're going to try to keep it in a tolerable range for the patient. You know, people use anything from acupuncture to medication to any of our modalities and such to calm down some of that pain. Ease into it. If you force it, they're just going to contract against you. Okay, what else do we have? Precise control of the joint position. Make sure they're not cheating, using the wrong motion to do the job. If you're stretching someone's hip flexors and their butt sticking up out of the table, don't we call it a positive Eli test? Okay, you got to get the butt down, otherwise you're not stretching the hip flexors. You're cranking on their SI joint, their low back. Everything's moving but what you want moving. And sometimes on my dancers, I work professional dancers, amateur dancers, I got to put my whole body weight on them to keep that butt from lifting up. These people are tight. So you need to have good body mechanics. You need to be precise in what you're doing. Okay? Recruitment of phasic muscles. Why do we keep the contractions pretty low? Well, if you look at some of the literature, what muscles are typically short and tight that you're stretching on people? Would you say they're the postural, slow twitch tonic muscles or the more phasic, fast twitch muscles? Which ones are short and tight? How about hamstrings? Who thinks hamstrings, gastroc? Postural muscles, slow twitch muscles. So they did more EMG studies and they found out postural muscles or slow twitch muscles that are typically short and tight, needing a stretch, are going to contract at low intensities, below 30% of maximum voluntary contraction effort. So if you're asking a patient to contract more than that 25 to 30%, you're calling in your fast twitch phasics, as opposed to the muscles you're actually looking to stretch. It makes sense? Postural tonics. You can look at the work of Dr. Vladimir Janda, J-A-N-D-A, Janda, if you want more information about tonics and phasics, but just giving you some of what's out there in literature. This is from EMG studies. Make sure your counterforce is distinct, okay, within the tolerance. And have them breathing, right? When you're trying to stretch people, people are in pain, they're nervous about what you're going to do to them in therapy, so their sympathetic nervous system's kicking in. Their fight or flight response is kicking in. Have them breathe. That breathing will turn on the parasympathetics, it'll calm them down, it'll make it easier for them to tolerate what you're doing and to relax. And how about you? Should you be breathing too? Yeah, very important. Everybody should be relaxed. Okay, muscle energy interventions, lower extremities. We're going to start with the lower extremities. Because for most of our patients, what are they on? They're on their feet. So whatever's crooked downstairs is going to affect whatever's happening on the kinetic chain above, upstairs. So you're going to start looking at lower extremities. Of course, you look at posture. Again, I'm not teaching these today, but just to review, make sure you check the posture for symmetry, measure the range of motion. You know there's normative reference data for all of this, for goniometry, look and see. But what if you're dealing with the sports population? Like my dancers, do I want to give them back their normal American Academy of Orthopedic Surgeons goniometry chart, range of motion? They won't be dancing. Broadway will say, have a nice day, see ya, right? So you have to know what's the range of motion for that person's physical performance. These dancers are chosen when they're little. The teachers pick out who's got those nice hypermobile body parts. Those are the ones we want. What happened when I turned 12 or 13? They kicked me out of dance. You out. You out. You're a klutz. You don't do a cartwheel well. You can't split properly, and you're out of here. And I was very fortunate because who do I see in my office when they hit 15, 16, and the body has changed shape? I see the girls who were not kicked out of dance who should have been, with that miserable malalignment syndrome. Like, how are they dancing? They're shredding their muscles, and they're doing it 7 days a week. You're laughing. Some of you are familiar with some of this. How about the shoulders? So I'm going to pitch a baseball. You give them 90 degrees of external rotation, they're not pitching. You could look in things like Journal of Biomechanics and look up for sports or certain physical performance activities what kind of mobility or strength do these people need. It's well documented in literature, any major sport. Okay? So your tone, your strength, your special test, your functional test. You want to increase range of motion around a joint. This is just a little protocol in your mind's eye. What do I do first? State the limitation. Hip extension 0 to 5 degrees. What's normal? 0 to 30. What should my dancers be? Oh, 0 to 85. Okay, that's going to be a little different. What muscles are short and tight? The hip flexors. What are the hip flexors? Iliopsoas, rectus femoris, pectineus, adductor brevis, tensor fascia lata. Okay, so you have to know where these muscles are, because I'm going to tell the patient this is where you're going to feel the stretch. If they feel it in the wrong place, I'm doing the wrong thing. So I always tell the patient, and I touch them, this is where you should feel the stretch. And name the muscles. You should remember what the muscles are, right? Stretch into the barrier gently. Barrier means you feel that resistance to motion exponentially increasing as you go farther and farther into the motion. So take up the slack, go against that barrier, that passive end range. That's when you're doing your contract, relax, your post-isometric relaxation, right? 3 to 5 reps. You shouldn't have to be here all day doing this. If you're not getting a goniometric change in 3 to 5 reps, maybe you need to do a little soft tissue mobilization first, some myofascial work, fascial release, whatever you call it these days, deep tissue massage, Rolfing, it's all the same. It's all connective tissue work. Okay, and reassess. So I'm just going to blow through the slides here because you have these all in your book. I'm going to ask for a volunteer to come up and go through the hand positions. I won't actually do all the stretches because I want you to try some of them on each other, but just show you the hand positions and correcting where people will typically compensate or substitute for the motion. Now, I'm sure there's no one here who's ever missed doing a hamstring stretch, but we're going to put it across the kinetic chain just to get you the concept so we're all on the same page, because later when we're figuring out a left sacral torsion and your brain is twisted, you have to start somewhere. You're going to start with the lower extremities. So hamstrings and glutes are primarily what's limiting a straight leg raise, right? Hip flexion with knee extension. And what about the ankle? You think that might limit some of the range too? What should I be doing to the ankle if they have a knee flexion contracture after their total hip replacement? Shouldn't the ankle be involved? Dorsiflexion, right? I see too many people used up all their Medicare benefits, right? And they come in with that little 15-degree knee flexion contracture like 6 to 8 weeks after their total knee. I thought you had therapy at home for 12 visits. Oh, I did. Well, did they ever touch your feet? No. They just bent my knee. Well, what was that therapist doing and where did they go to school? And who gave them a license anyway? So you have to look at the whole kinetic chain, because if the gastroc is restricted, you know that attaches the posterior femoral condyles to the calf. It's going to throw their balance off. And it'll increase their risk of falling, and since it's National Falls Prevention Day, we have to remember that, right? You have to scoop these patients up, or better off, keep them from falling in the first place. So these are simple, but they really translate into more functional activity. So I gave you here, these are with permission from something called Primal Pictures, which is based in London. They're really nice pictures of things. You see gluteus maximus and hamstrings, so you can remember where those muscles are. Hip flexor muscle energy, you're going to stretch the hip flexors. Notice again, hand position. You don't want that butt jumping up like the Eli test. What's the position? And I'll show you on the table. Iliacus and psoas, here's some of your primary hip flexors attaching the lumbar spine. This muscle is such a big issue for patients. The psoas covers 5 lumbar vertebrae. It attaches the intervertebral discs. It crosses through the pelvis, just anterior to the SI joint. So when patients come in, we talk about SI joint problems. You cannot miss the psoas because it's affecting the entire lumbar spine and the hip joint. Okay, it's a hip flexor as well as an external rotator. So if you see a patient come in and they're kind of anterior pelvic tilt and externally rotated on that side, what muscle might be tight? Just looking at their posture. Psoas. So something to think about, remembering the muscles and where they are. And if the psoas is attaching the intervertebral discs, how many patients have damage in the intervertebral discs? Like most people above the age of 21. Okay? They did studies, and I've seen a few different studies, typically done on the convenience sample, like college kids. And they're like 20 years old, and they find out 20-something% of them have herniated discs on MRI. No back pain, no problems. So do we care that they have a herniated disc? If you start cranking on their psoas, and they have disc damage, and the psoas attaches to the disc, say you did a strong eccentric contraction of the psoas, what might you do to that disc? you might cause a little more damage. I have 2 patients suing their previous physical therapist for doing just that to them. So they have plenty of money to pay me now for therapy from here to Kingdom Come, right? I come from the most litigious county in the United States, so I'm well familiar with this issue. So sometimes the contractions being lighter, as I mentioned earlier, are better. You're less likely to cause damage because you need to remember where these muscles attach. It's going to influence a lot of things. So this is an important one, of course. Another direction, say the patient can't lay in prone or supine for whatever reason, they have gastric reflux or their sacrum hurts or any number of reasons that patients tell me. Side lying is usually the most comfortable for patients to stretch the hip flexors. Okay, Thomas stretch, another direction to go. Hip adductors, these are all muscles you're going to want to look at and stretch if they're limited before you get into pelvic muscle energy, lumbar muscle energy. There's your adductors coming through inside of the thigh. Okay, these are attaching directly to the pubic bone. Later we're going to be looking at superior pubes, inferior pubes, somebody who has an in flare of the pelvis, out flare of the pelvis. These muscles are attaching there. So if we don't address the muscles, you can sit and do muscle energy for those flares or those descended or superior pubes. It's not going to hold because you didn't address the muscle. So going for those long muscles of the legs that attach to these bones first. Okay, abductors, gluteus medius and minimus, very important muscles for standing balance, for ambulation, transfers, again, also connecting pelvis to the hip. Okay, these are very important here, especially when you see people with sacroiliac joint problems, pelvic problems. Because the pelvis is asymmetrical, there is a problem in the length-tension relationship of these muscles, and you're going to find that they have some weakness. Some patients it's significant enough that you see a positive Trendelenburg sign, the hip drop. Some people will just be doing a unilateral stance and see, how is their weight, and you might see that pelvis drop on one side. Or, oh, I can't stand like this. It's killing my back to hold my leg up in the air. That's showing you an instability of the pelvis right there. Instability of SI joint. What does it tell me? Testing simple gluteus medius and minimus. They need a sacral belt. They need a belt to stabilize them. So this is what we'll be looking at this afternoon. This is just a precursor, and tomorrow, of course. Lateral rotators, piriformis, attaching right to the sacrum, attaching to the coccyx, attaching to the pelvic floor. How many people treat patients with pelvic floor problems? Okay, very important. And it's not just women. Interesting studies on myofascial work, this energy work for muscles in guys who have chronic prostatitis, ladies with pelvic problems, making a difference. Those muscles attach there. At an extreme, this can start affecting people's bowel and bladder function. And the neurologist will say, oh, you have a quarter equina syndrome. Oh, really? Oh, you can't hold your urine. You have a quarter, and then you find out from EMG there's no quarter equina syndrome. Just the muscles that happen to control the sphincters are either on a stretch because of abnormal tension in this area. These are things that have to be addressed. And these are some of the complaints that patients may present when you're doing your lumbar pelvic SI joint muscle energy. Remember, there's organs that attach there. You got the uterus, you got the prostate. It's going to be pulling on these muscles. It's important that that's evaluated. If you don't do that type of evaluation, you send, like you have someone right here, just raise your hand again, someone right here who does specialize in that area. Same thing with me, like somebody comes in, well, I have a 3-month-old with cerebral palsy, can you treat her? Like, I'm not an expert in kids. I send them off to my friend Jody, right? You go see Jody. So refer when necessary if it's not something you specialize in. Okay, so there's your piriformis, as you know. It comes from the sacrum going out to the greater trochanter. Depending on the study you read, in something like 80-something% of people, that sciatic nerve is under the piriformis, and they say around like 12% or so, the sciatic nerve goes right through the piriformis. So if it's tight, what's it going to do to that sciatic nerve? Compression neuropathy, so you'll see the sciatica. It's very important to look at this, and of course the other deep 6. Hip medial rotators, gluteus medius and minimus. So we're going to stretch all of these coming up. A hip hiker, many times you'll see people with their pelvis is shifted or they look like they're high on one side. Well, what muscles are attaching to the ilium that might be pulling it up? You might say, oh, that patient has an upslip. Oh, but it looks like it's a downslip on the other side. Well, is it an upslip on the right or a downslip on the left? Oh, I don't know. Just a quickie on terminology. Osteopathic terminology. We name the dysfunction, this will come up again later, and it's in your book. We name the dysfunction by the hypomobile side. The side that is stuck is the side you name the dysfunction. So we mentioned if they have a tight quadratus lumborum, that goes from the lower ribs to the iliac crest, okay? Let's bring that up for you here. Ribs to the iliac crest, and also there's usually slips, doesn't show in the picture, but usually transverse process of L4 and L5. The quadratus lumborum also connects. The QL also connects directly into your respiratory diaphragm fascia. So somebody who says, you know, when I took that deep breath, I got a sharp knifing pain right there in the QL. Well, guess what? They attach. So again, knowing that these things attach, or you have people do breathing exercise with it, if that QL is tight, it hikes up the hip. You might see, oh, they have an upslip on that side. Well, how do you know it's not a downslip on the other side? We'll do tests to see which SI joint is locked. The side that's locked is the side you call it. So if the right SI joint is locked, we're calling it a right upslip. If the left SI joint is locked, we're going to call it a left downslip. You see what I'm saying? So it's semantics. If anything drives you nuts when learning this, it's the semantics. So get that terminology down, you'll be good to go. Okay, so and here we have one of the best views of Manhattan, by the way, is from top of the Rock, Rockefeller Center. So Melissa has graciously volunteered, and when she starts singing, we'll put her on American Idol or The Voice or one of those, right? Okay, so hamstrings and glutes. So check your straight leg raise should be, hey, she's pretty good, huh? Where are my patients? Down here. Where are my dancers? Up there. So say she was limited, we're just going to pretend with these and you'll try with each other. Say she's limited in straight leg raise. Of course, you want to stretch across the hip extensors, which is glutes and hamstrings, to behind the knee. What are we going to contract? State the limitation. Oh, straight leg raise, 0 to 75 degrees. What should it be? 0 to 90. What muscles are short and tight? Glutes, hamstrings. Okay, push your leg down toward the floor lightly and hold it 1, 2, 3, and relax. And now, wouldn't it be easier for me if I just rest your leg on my arm? Okay, and how about, does that free me up to add a little something extra? Ooh, and we're getting a sound effect too from the patient. So we know. How about if her foot's going this way or that way? Is that proper? How about having that subtalar joint neutral so you get that gastroc as well? Because that's what the patients do. They abduct, they pronate, so make sure that subtalar joint right smack in the middle. Should we be squishing the knee on the kneecap? I see therapists do that all the time. Oh, I'll get that knee straight. They give them chondromalacia. Now they'll be a permanent patient for other reasons. So distal femur, push down lightly on my shoulder, nice and easy. What if she said, oh, I was having back pain? What could we do with the other leg that might make her more comfortable? Bend that other knee. I'd put a pillow under there. It might ease her up a bit. Okay, see how that was a little easier? Mm-hmm. Okay, what if she's having tingling and numbness down the leg? Should we progress? No, you have to find out, is she having tingling and numbness because she has a positive straight leg raise, which for disc is typically 0 to 30 degrees. Okay, or what if she's having neural tension, especially as I start extending the knee and then I add that stretch of the gastroc? Sciatic neural tension. I might just back it off a little bit. Oh, it's tingling and numb when I'm here. Well, if I back off a little, you're still tingling and numb down into your foot. Oh no, that's okay there. I'm going to work in that range that doesn't aggravate the nerve. Get right up to it, the edge of it and work. So push down, push toes 2 into my hand, and relax. So do the whole kinetic chain and work your way up. So hamstring and glute. What's next?
The hip flexor mat.
So hip flexors. Let's do the Thomas test. You're going to come sit on the edge of the table. With this, not all patients like to be on the edge of the table, so you know, my little old ladies in their snowflake hospital gowns might not appreciate being on the edge, so modify if you need to. Basically looking to see, we want hip extension, normal 0 to 30 degrees. Lay back on your back. Scoot your butt to the edge all the way. Okay, good. Hold these up with your hands for me. Now, the biggest issue people have here is they don't have the ischial tubes right at the edge of the table. They have the patient too far up the table. As the femur extends, the femur hits the table, it's a table restriction instead of a hip flexor restriction. We'll demonstrate this side since it's by the camera. Let this leg go down. I could even help her hold this up by leaning in, so you could relax. If she's not relaxed, it's very hard for her to let this go. Better there. What do we think of these hip flexors here? Oh, we have some work to do, guys. Who's your partner? You got some work to do back there, okay? So stabilize what you don't want moving, mobilize what you want moving. So stabilize, you want iliac crest. So I'm going to see where's ASIS, where's iliac crest. You okay with me holding here? Mm-hmm. And let me just see what little passive motion. Oh, a little tight there. Is the back okay?
Right now, yeah.
Right now, yeah. If the patient has back pain, I'm going too far. She's compensating using lumbar hyperextension or sacral flexion for hip extension. So we just make sure. Sometimes I'll even put a wedge under the sacrum to put her in a posterior pelvic tilt to make sure that she's not hyperextending her back. You will feel the ASIS, anterior superior iliac spine, hopping up into your hand if you're failing to stabilize her. You're going to feel stretch here. I don't want you to feel pain anywhere though. Now her leg's down here. What if her leg was out here? What muscle's tight? Quads, rectus femoris, from the AIIS to the knee. So we have two issues to deal with, the hip flexors and the knee extensors. So I'm going to say the hip flexors first. As I push down, you're going to feel stretch through the front of the thigh. I want no back pain, and I want no kneecap pain. Because if the rectus is crazy tight, it'll drill that patella right into the femur, could give them chondromalacia. And often they'll tell you it feels like they got stabbed with an ice pick. So it's not a comfortable sensation. You okay? I might give her a little extra support. Is that better?
That's good.
Yeah, but you feel a little stretch in here? I'm just going to go slow. Let your leg drop. I could even put my leg under her leg to give her more support. How's that? Feeling the pull yet in the front? Okay. Help me hold this up. Tighten up your belly. Good. Better?
There we go.
Good. Little posterior pelvic tilt. Again, I'd put a wedge under her sacrum so she wouldn't have to do that. Pull slightly up toward the ceiling with your knee. Very slight. Oh, hardly at all. Too much. Too much.
Sorry.
Hardly at all. Just an ounce. And relax. And let it drop. That's good. Better if I hold you here? Mm-hmm. So I really have to press in her ASIS because it's popping right up. Tiny bit. Pull up toward the ceiling. And I'm going faster than I would with a patient just for demo purposes. And relax. How are you doing there? We got a good victim here. And we're stretching. How's the kneecap? Fine. I keep my leg under there to keep her from hyperflexing in case it's too much on her kneecap. And one more, a little up, tiny bit. If they're pulling up too hard, I tell them, imagine lifting your leg. Don't even do it, and they still pull. And relax. That imagining fires a few muscle cells. And relax. Let it drop. Let it drop. How are we doing? Any different than where we started? Yeah. Okay, so 3 to 5 reps. Help her out of it. Don't ask her to haul her entire leg up on her own. Now we're going to try it in 2 other positions, if that's okay with you, prone and side lying. So come sit up, help her up. Now go on your belly with your head up this end. Now, being that she is so tight in those hip flexors, prone, she's very likely to just pop right up at her posterior pelvis, which is what we want to avoid. And in the clinic, I would have several pillows. In the clinic, I also have an electric table that I could push a button and drop the legs down from the waist to put her in a little bit of flexion or neutral for the back. If I don't have an electric table, a couple pillows under the hips, right, to put her in a little bit of flexion, which we don't have, so we're just winging it, but these are things that you could do. Can I just try on this side? Sure. Okay. A little close. Good. Make sure she's close enough to you that it's comfortable for you. You're not reaching over the table. You're going to feel me lifting this leg here. Now, keep the pelvis down. Let patients know I'm going to be pushing on the back of your hip here so you don't hurt your back. And again, a couple pillows under there to stop that excessive lordosis that you're seeing. Come back into some hip extension. Notice I have the knee flexed. If that was too much, I could extend her a little more. I could really decide how far I want to go with her feedback. So there's some tension right there. You okay with that? How's the back? Fine, good. Gently pull your knee down toward the table, lightly, less than that, and relax. So she holds it 2, 3, and work into a little more extension. Sometimes they're so hard to stabilize, I'll put my whole forearm on there, and I'll put a pillow underneath their thigh. So conveniently, I brought my leg today. That works. See how this picked right up? Down, girl. You okay there?
Yeah.
Yeah, but it's really pulling, isn't it? She's not sure she's okay there. Can I keep going, or is it too much? Now we can work rectus too. Push your foot down toward the table like you're kicking a ball, lightly. So resist the extension and relax. You get a mad stretch when you start adding that knee flexion. How's that? Good? Feeling all through the front of the thigh?
Yeah.
Good. Back's okay? Mm-hmm. See, so I'm always checking in with the patient, and we're letting go. Again, for demo purposes, we're just moving right through these. Turn and face the audience there. I'm staying here so you don't fall off the table. Side lying is another option. Side lying, you're going to pick up your right knee, hold it for me. Okay. in the clinic, I have straps, and I strap the leg down so she's not sitting here having to hold it and strain herself. I'll put my hip, I'm going to put my hip right up against your lower back and hip here. This will prevent her from rolling back off the table. Because if I start extending, I'm just going to let you roll, but I won't let you fall, just for demo purpose. If I start extending without holding her, what did she do? Her pelvis starts turning. It's lumbar rotation as opposed to hip extension. If people don't have the hip extension, they're going to excessively be rotating the lumbar spine over and over and over with every step they take. And they're wondering, why do they get wear and tear here with the tight hip flexors? So here I'm going to wrap the leg around me, put my hip against her, monitor ASIS, iliac crest, start getting some extension. Now see the knee is flexed. Is she extending much? Nope. Feel the difference? I might put something under there like a ball, a towel. Drop that leg for me. Lean on me. Good. A little better there?
Yeah.
Let that go. Yeah. This way it's not so much. So have her lean on something. Those huge rollers, foam rollers work really well underneath the thigh, so I don't have to hold her leg up. So those are some other positions you could use. Adductors. So let's go on your back. Now if the adductors are short or tight, of course, you want to work on that. It should be 0 to 45 degrees. Palpate the ASIS, iliac crest at your stabilization. Abduct, how far do they abduct? And most people will laterally rotate at the same time. So just see where they get with neutral first. Say she was tight here. Adductors right from the pubis down to the femur and inside the knee, the pes bursa region. Pull your leg together toward your other leg, lightly. Hold it and relax. So resist adduction, stretch. What some people do is the whole other side's picking up. I might stabilize that side if it's more of an issue. Feel a difference when I do that? Now squeeze together and relax. I'll often just tell them, bring this leg toward that leg, and I tap them so they know exactly where to go. Abductor mat. So we'll just show the other side for convenience on the camera. So many people have tight gluteus medius, gluteus minimus, and of course those muscles attach from iliac crest, lateral ilium into the trochanter. The patient may present with snapping hip, snapping tight tendon right over that trochanter, iliotibial band syndrome, tightness of the IT band, positive Ober test. These attach all the way down, IT band all the way to the lateral tibial plateau. So these are affecting both the hip and the knee. Now to stretch, because the other leg is in the way, we have a few choices. You can adduct in flexion, or can you hold this leg up in the air for me? Or you could adduct more neutral if she's able to hold her other leg up out of the way. Okay? So either way, push your leg out toward the audience. So she's resisting abduction, relax, and stretch, and she should feel that pull coming bilaterally here. If she wasn't able to hold her leg up, I might put a little stool over there and move a little bit out of the way. So the lateral rotator, this is going to be the deep six, and piriformis of which is one of the very important muscles there. We're going to do this side. I like to bring them up, and I use traditional goniometry position for measuring. It's just convenient, although there's many other ways you could do this. External rotation should be 0 to 45 degrees. I often find people have extra external rotation and not enough internal rotation. Not her problem. She's pretty flexible here. So we'll pretend she isn't. So I'm letting her stabilize her thigh against me, hold the knee. If she's got a torn cartilage in the knee, should we be torquing at her knee? Probably not. You might have to do a different way. So externally rotate. If she can't externally rotate that far, you're going to push into me this way, and I show her where to go. Ready? Push lightly. Hold it. 1, 2, 3. So you resist the medial rotators. Relax and stretch. And that's just a general stretch to increase internal rotation. Check and see. Very often this is restricted. People have degenerative joint disease in the hip. They might have labral tears. They might have a joint inclusions there. So be very careful if they're having impingement syndrome in the hip that you clear that first and don't start cranking. If they're having sharp pain in the hip joint, back off, examine more carefully first. So if she's limited medial rotation, you're going to pull your foot this way. Ready? Go ahead, pull a little bit. Usually it'll get tight in the muscles, and then the capsule, and finally the joint will lock up and relax. And good. Now she has plenty of motion, so we're not going to push that. Another way to do that would be in prone. Would it be okay to lay on your belly? Again, someone with an anterior pelvic tilt, exaggerated lordosis, I'd put the pillows underneath them, or might not do this so much in prone, but same thing you can do. Stabilize the hip here from posteriorly, external rotation, and that hip really likes to move. Internal rotation. Pull this leg up into my fingers, and I'm tapping so she knows where to pull, and relax. And if I'm going into external rotation, push your foot into my finger sideways, good, and relax. Get that lateral rotation. Bear in mind too, her hip is extended if she's prone. What position was she in when we did it before? Flexed at 90 degrees. You're going to get different fibers of the muscles based on whether she's prone, okay, with hip extended or flexed, or anywhere in between. Just keep that in mind. Turn face up now. In someone who for some reason, maybe they had a tremendous knee instability and I can't put any pressure across the knee, I could do some of this just by rolling the femur. If I roll the femur in, the medial rotation, roll your whole leg out like this toward me when I say go. Lightly, ready, go. So she's rolling her leg out and resisting external rotation, relax, and then rolling in. Feel how that pulls up into the hip? And then for increasing external rotation, roll your thigh in, lightly, and relax, let it go, and I could roll her out. So I could use the femur as a lever too, like a big rolling dough, okay? And you get some nice motion there if you're having an issue of the knee. Hip hiker. Hip hiker is a nice one to do. For the sake of demo, we'll pretend that her left quadratus lumborum is tight, her left ilium, just hiked it up for me. Looks like she has a short leg, that whole side is hiked up. Okay, iliac crest on level, ASIS, PSIS, everything higher on one side, on the left. You can just relax. We'll pretend you have that. So we can use the leg as a lever again as long as she has stability in the knee and hip. You're going to feel a stretch, so I could do a little traction through the thigh. Sometimes if they're really tight, I'll traction through the leg from here. Feel the pull. And you have to kind of grade the traction up, because when I start pulling, I'm holding the distal tibia fibula, so I don't start cranking on her ankle. First, it's going to unload the knee, then the hip, and gradually work up the kinetic chain. So there's a little the knee, a little more. Feel how it goes up? And now it's up toward the back. Now you're going to pull your leg up to make it short when I say go. Let me get a little stretch going. Feel the stretch? Now pull your leg up, make it short. Hold it, hold it, hold it, and relax, and stretch. So she's resisting hip hiking, and then I'm stretching to lengthen her leg. So that works quite nicely that way as well.
So I often have patients with a lot of psoas issues and dysfunction. So doing a traction for the hip hike.
If we're doing a quadratus lumborum release for the hip hike and the traditional traction, distraction, and I ask her to pull back, they might have a lot of discomfort in the front of the hip. So if the psoas is limiting their ability to tolerate the traction through the leg because the hip's extended and maybe they have a little psoas contracture or tension, I could put them in hip flexion to get a release and then work from there. Or I could even cradle the leg and traction just through the femur if they have an issue of the knee. So different options. That can be done in side lines if you roll that way. Come back toward me a little bit. So again, for the hip hiker, QL, remember it's not just the quadratus lumborum that could be tight, the lower erectors, the internal and external oblique where they crisscross the hip. So lower obliques, iliacus and psoas, all these other muscles and the fascias are pulling as well. I could do the hip hiker release, tractioning, and side lying if they're more comfortable. I could have the bottom leg bent, which might make their back more neutral, and I could do the traction. Now pull your leg up towards you, make it short. You can see the contraction here, the iliac crest elevating, relax, and then stretching, dropping it down. So just different options, and you could add more hip flexion, or if you want more hip extension, depending on exactly how you want to stretch, you can modify it. Okay. Great, thank you. Yeah. Okay, let's move into what we want to get into, spinal muscle energy concepts. Okay, slide number 43. How do we describe the motion? Anyone else have a spine model here? Or if you have your book, open your anatomy book to look at the spine at whatever page you happen to have. Okay, when we're describing motion here with muscle energy, we use very specific semantics or nomenclature. What's the terminology? That's what gets most people confused. Some people name things by the position the joint's stuck in. Some people name things by the motion restriction. It's all difference of terminology. So first we want to see, what are we actually talking about? We're talking about spinal muscle energy. Today we're looking specifically at the lumbar spine at this time. We're looking at movement of the superior vertebra on the inferior vertebra. So if I'm talking about movement of L3 on L4, okay, movement of the superior vertebrae on the inferior vertebra. Because there's a whole lot of vertebrae. Sometimes a single vertebra gets stuck out of place. Sometimes multi-segments get stuck out of place. So it depends on what you're looking at. So the positional motion we're testing is motion of the superior vertebra on the inferior vertebra. So if I'm talking about, oh, we're doing a correction of L4 is flexed, rotated, and side bent left, we're talking about L4 moving on L5, right? So I just want to be very clear with that. Spinal muscle energy. I gave you some little pictures of some things that happen. This picture here, like the fifth one over, is probably the most interesting. So if you look at these two, opening the facets. When the body flexes at the lumbar spine, the facet joints open. And actually there's a nice little picture of it right here. Can you see the picture? It's also in your book. Notice that at this side the facet joints here are together and approximated, and on this side it's open. So this side is flexed on the right and the other side is extended on the left. Does everybody see that? Here's where, say, the vertebrae are both even. This happens to be thoracic vertebrae, but it's the same concept. So you're going to palpate the transverse processes of each vertebrae to feel, are they symmetrical or not? That's our key to most of the lumbar muscle energy. Those transverse processes, if they're neutral, should be symmetrical. Both sides equal distance, say, from the floor or from the feet. If you see that they're asymmetrical, as it is here in this picture, the right facet is open, the left facet is closed. The transverse processes of that vertebrae are going to be in a different place. Okay? What happens when you're forward bending? The facets open. As they open, the transverse processes move anteriorly. So if you're palpating the transverse process from standing neutral into forward flexion, you're going to feel those transverse processes move anteriorly or feel like they're getting deeper. And it helps if you actually take your fingers and do that. So you know that's what you're going to feel. Flexion, they move this way. So go through the little motion dance here. Okay, backward bending or extension. This is extension of the lumbar spine, the upper vertebrae on the lower vertebrae, say L4 on L5. During extension, those transverse processes of the upper vertebrae become more prominent or posterior. They're easier to palpate. They will stick out for you. So if you're palpating and you feel a transverse process sticking out, would you say that's flexed or extended? It's prominent, it's posterior, it's extended. What about the one that's deeper? What is that relatively? Flexed, okay, just so you know, because sometimes they're supposed to move together, but sometimes they don't. A facet joint can be locked on one side, has joint capsule dysfunction, maybe they twisted and got stuck there, maybe there was an accident, something caused them, a muscle spasm. Muscles attach to all of these joints. Multifidi, rotatories, erector spinal muscles. Muscle spasm could cause this to rotate and side bend out of place. And we could palpate that because we'll see asymmetry in the transverse processes. Okay, rotation, that's around a vertical axis, and the motions of rotation and side bending or lateral flexion are coupled. We're going to talk about Fryette's rules of biomechanics, how motions couple in the spine. It will be different if someone is palpated in neutral than if you're checking them when they're flexed or extended. You know how many people have patients come in, Doc, I bent over for the soap and I couldn't get up. That's a little different than palpating them in neutral. So the motions of side bending and rotation are always coupled. Either they occur together in the same direction or they occur in opposite directions. So let's take a look. This is from Dr. Phil Greenman, and he says basically somatic dysfunction, what we described before as ART, asymmetries, palpated, range of motion R is deficient, and T, tissue tension, is abnormal. That's a sign of your somatic dysfunction. He defines somatic dysfunction as impaired or altered function of related components basic of the body framework. And although we're dealing with mostly skeletal landmarks that we're using here, be aware that everything's affected. The circulation around that area, okay? The sympathetic nervous system, as we mentioned with those facilitated reflexes, can be impaired. Okay, myofascial structures, the joint capsules, etc. The lymphatics, the nerves could be pinched by this malpositioning. So although we're talking mostly about the muscles and reflexes today, bear in mind that there are other factors influencing this somatic dysfunction. I mentioned already it consists of ART, asymmetry, range of motion deficits, and of course you could palpate tissue tension changes, you feel fibrosis, you feel those snapping taut bands in your notes. You could write about them, positive jump sign, positive twitch sign, when I snapped over that tight guitar string of a muscle. The description of some of that is easily found in a book by Dr. Janet Travell called the Trigger Point Manuals. And she has a really nice description of how to measure pre and post treatment and define how those trigger points change, how the taut chords change. Gives you some nice documentation information. So here's our Fryette's biomechanics laws. Law 1 is neutral or type 1 coupling. And type 1 means you're palpating the patient when they're neutral. So you're looking at them either neutral laying down on the table or neutral standing. It could be even neutral and sitting as long as they're sitting up straight. And in neutral, there are coupled motions here. Okay, there's a neutral anterior-posterior curve. We know there's typically a little bit of a lumbar lordosis there. We're considering that normal lumbar lordosis to be neutral. Okay. In the neutral position, side bending and rotation of these facet joints occur to opposite sides. So normally in neutral, if you side bend right, the vertebrae automatically rotate left. And we'll use that information to ask patients to contract, either in side bending right or rotation left, because they go together. If I ask a patient to contract just in side bending right, I don't really even have to add the rotation component because it'll automatically happen just because of the mechanics of how the joints move. So memorize that. Neutral mechanics, if you're palpating, where are these transverse processes? Are they symmetrical or not? If they're asymmetrical, okay, I can feel that one is rotated to the left. If it's rotated to the left, which way will it be side bent? Neutral mechanics. To the right. Okay, so it's opposite. So you're going to be looking for that on your palpation. This applies to a group of vertebrae, so it's multi-segmental. When you palpate these neutral type so-called dysfunctions, you're going to notice several transverse processes in a row are all asymmetrical in the same position, say all side bent left. Let's say someone with a scoliosis would be a great example. Maybe they're curved to the left in the thoracic spine, maybe they're curved to the right in lumbar spine. That's a good example of a type 1 or neutral somatic dysfunction, many vertebrae together, because they're tight in the muscles and fascia on one side of the spine. So it's a multi-segmental problem. It's typically a compensation for something else, like why would someone be side bent to one side? Maybe they had a spasm on one side, maybe they have a leg length difference causing that, so it could be many things. It's typically a compensatory issue with this, okay? The facets are not engaged, the ligaments are slack, so that's why they all move in opposite directions. The ligaments are slack. Okay, non-neutral. If you're palpating a patient when they're flexed, maybe they're flexed in sitting, maybe they're on all fours flexed on the table, okay, or standing, they're flexed forward. The spine's not neutral, so spinal mechanics is changed. Type 2 is called non-neutral mechanics. In this case, rotation and side bending occur together in the same direction. So if the person side bends left, they're automatically going to rotate left. So when you're doing muscle energy later, we're going to be talking about contracting not just in one plane of motion like we did this morning with the legs. Oh, the hip flexors are tight, so contract them and then extend. You're using just one plane of motion, flexion, extension. Here we could add other planes like rotation, side bending, extension. But because these motions occur together, you don't necessarily have to address all three. Does it make sense? It's going to happen automatically. You'll see that reflected when we do our muscle energy. This applies to a single vertebrae. So type 2 coupling is most typically found that you're palpating when the patient's flexed. One transverse process is very prominent. Or you're palpating when they're extended. One transverse process is prominent and sticking out. It's usually a single one. Okay, so that tells you, oh, we have a type 2 dysfunction, And this is where you see more of the dysfunctions occur because the capsules are tight, the ligaments are tight, everything locks up. You'll see it lock up, the facets will close on one side, open on the other side, and it's asymmetrical. The last one, type 3 mechanics, this is the easiest, Dr. Phil Greenman. Motion loss in one plane affects motions and limits motions in all the other planes. Conversely, gaining motion in one plane helps gain motions in all the other planes as well. So you may find, oh, that patient I worked on that had the tight hip flexors, I noticed her adductors were also tight. Although I didn't do the adductor muscle energy because I didn't have time today to do that, I noticed she had more abduction after I did the hip flexion stretch. Wow, motion increased in other planes that I didn't even actually physically work on. So it's a little bonus. Working on a joint in one direction helps the other directions. Remember, the fascia connects through all the muscles. If anyone familiar with Fascia Research Congress? Started in, up by Harvard Medical School in Boston, 2007. Some of the latest research. Just for your information, if you write this down, it's at www.fasciacongress.org. Definitely worth writing down because it's got some very new information and different from things that we've learned before. Even anatomy is different than what we learned before. If you are working on muscles that you think cross only one joint, you're affecting other joints as well because the fascias connect. So be aware, working on one joint in one direction is going to affect everything else around it. Just a quick example, they took, unlike what we typically see in research, what do they use? Dead people. Dead rats, dead people, typically not animate objects. Or they use mechanical models in a lab. Most of our convex-concave rule of joint mobilization is based on mechanical models in a lab, not even real people. If you look at some of the later studies on real people, convex-concave does not necessarily work for everybody. Depends on whether they're hypermobile, hypomobile, or otherwise. It's well evidenced in the Physical Therapy Journal. One study, Jennifer Flowers, as an example. They took a regular, live guy, put him in an MRI machine, and they looked to see what happens between the ankle and the knee as we start flexing the knee. What happens to the connective tissue? Now, if a muscle like the soleus, if you're going to stretch the soleus, does it matter if you bend the knee or not? Will moving the knee affect the soleus? It affects the gastroc because gastroc crosses the knee. Typical biomechanics. It doesn't necessarily affect the soleus, we're taught, because the soleus doesn't attach above the knee. But actually on the MRI it showed that it did. You can move muscles of the peroneals and it affects the soleus because the fascias connect. You'll actually affect muscles at tibialis anterior, gastroc, soleus, peroneals just by putting the knee locked and flexing and putting the ankle locked and flexing, extending the knee. So what we're saying is it's all connected. Movement in one area affects movement in all the other areas. Lack of movement consequently does the same. Make improvement in one direction, you're going to see improvement in other directions. So that's the type 3 mechanics that Greenman was looking at. So there's different language used in the literature. And I found when I first started taking muscle energy courses years ago, I was completely lost because I learned one terminology in school and that teacher used a different terminology. Halfway through the seminar, he switches terminology. So we're going to do one thing. We're going to state the position the segment is stuck in. Some people state the motion barrier. Some people state the position. We're looking at position. This is classic osteopathy. L4 is flex, side bent, and rotated left, period. What motion is limited? Extended, side bent, and rotated right. Just the opposite. So here we're going to state the position. Where is the joint? We're going to take a picture of it in our mind's eye. There it is. It's flex, rotated, side bent, left. How do we have to move it? Got to move it out of that asymmetrical position. We have to extend it, rotate it, and side bend it to the right. Motion testing. So we're going to use the transverse process, TP. Some people use the spinous process as well, but the transverse process is really the key to determine the dysfunction. Their question is, as I'm palpating, which transverse process is prominent? If it's a single one, it's probably a type what dysfunction? Type 2. If it's a whole bunch of vertebrae with transverse processes prominent on one side, oh, that whole left side is really sticking out. That's going to be a type 1 dysfunction, neutral. Okay? Compare the motion segments. We're going to ask the patient to palpate with them neutral, palpate with them flexed, and palpate with them extended. Transverse process will move differently depending upon where the facet joint is stuck. Is it stuck open or stuck closed? Is the right side stuck open and left side stuck closed? Just the opposite. So palpating is key here. The motions are coupled. Okay, so flex to the level of asymmetry. If you looked at someone in neutral and you said, wow, that L3 on the right is sticking out. Okay, in neutral, what should happen? It should be symmetrical. What if you asked that person to flex? What should those transverse processes do when people flex? They should both go deep because the facet joint's open. So if it's stuck, extended on one side, will it go deep? No, you're going to see it's still prominent. So this is what we're going to compare. If you see the transverse process asymmetrical in one position and symmetrical in another, you know you have a dysfunction. Whether it's a flexion extension dysfunction or side bending dysfunction, right or left, will depend. We're going to practice all of this here. If you extend to the level of asymmetry, does it disappear or not? So if you found them in neutral, okay, the right side is prominent, and they extended and everything became symmetrical, where are they? They're happy in their dysfunction and extension. But if you put them in flexion and it gets much worse, that side is extended, the right side is extended, because it fails to flex and close, so it remains prominent to your palpation. Does that make sense? Yeah, so that's what we're looking at here. Okay, motion testing. I've described all of this here. We're going to look at it first in neutral. It's easy. First, palpate the spinous process in the lumbar spine. That's the midline bony prominence. Take the web space of your hand, come in over their iliac crest. The narrowest part of their waist is the top of the iliac crest. If you go from the very top of the iliac crest exactly medial, the spinous process level with the top of the iliac crest is L4. And then you know the bump below it is L5, and obviously the bumps above it are L3, L2, L1. So palpate from the iliac crest, find L4 and L5, count them up. So find the spinous processes, palpate where they are. If you put your fingers like a finger width or two lateral to the spinous process, you can feel transverse process. Transverse process of each individual vertebrae is slightly superior to that vertebrae. Now I would recommend to use either your thumbs, thumb next to thumb, and put your dominant eye between your thumbs, like so. Some people like to palpate with their middle finger or index finger. Put your dominant eye in the middle. So palpate. And if you put your thumb down, so your finger's like this, if you're using your middle finger, index finger, plant your thumb down so you have a little stability. If you're using your thumb, plant your fingers down so you have a little stability. You're not slipping, sliding all over the place. So palpate and see, is the transverse process prominent on one side or the other, or is it a group of transverse processes prominent? Now, another key to palpation, you do not have to press hard. Matter of fact, if you push too hard, A, you're going to irritate the patient, and B, you obliterate your sensitivity. It's going to be obvious which one's higher. Sometimes if you close your eye, you can feel more than see. Now, if you feel that one side is prominent, you may or may not, palpate across that vertebrae, both transverse processes, and ask the patient to slump or flex. From chin to the chest, flex the shoulders, flex the trunk. Neutral, where are the transverse processes? In flexion, they should deepen and be less prominent because the vertebra moves anteriorly in flexion. So the transverse process moves away from you, it deepens in flexion. L3 on L4 is neutral here. As they flex, the transverse processes move away from you and the joint opens. You can see the gapping. So the transverse process goes deep in flexion. As the transverse process moves posteriorly into extension, you see the facet joint close, and the transverse process moves posteriorly, becomes more prominent on your palpation. Is it a single vertebrae is prominent in neutral? That tells you that means a neutral type 1 dysfunction. Side bending and rotation are going to be in opposite directions. If you palpate a group of vertebrae prominent on one side, a group of transverse processes prominent on one side, that's going to be a type 2 dysfunction. That happens in flexion or extension. You're going to see side bending and rotation occur in the same direction. And we'll use these concepts to make our corrections later. The type 1 dysfunctions, we're going to assess them in neutral, find them in neutral. We're also going to treat them in neutral. The type 2 dysfunctions, we're going to find them in non-neutral or flexion extension. We're going to treat them in flexion or extension to correct them. The type 2 dysfunctions disappear in either flexion or extension. You're going to see them appear. If it's a flexion dysfunction, it'll look normal in flexion, but abnormal and asymmetrical transverse processes in extension. That's how you know it's a flexion dysfunction. If you find the asymmetry in extension, it's a flexion somatic dysfunction. If you find the asymmetry in flexion, it's an extension somatic dysfunction. If you find the asymmetry in extension, it's a flexion somatic dysfunction. This is all in your book. I gave you a little table to help you memorize it. Okay, find the transverse processes. So here's iliac crest. That's going to be level with L4.
Okay.
Okay, come a little bit lateral to that. And up, and soft fingers, really soft. And just feel, does it feel like one is deeper or more superficial than the other?
No, I don't know. Well, this one seems a little bit deeper.
Then feel the levels above. So L3, L2. So relax your body. Don't try to force yourself. Some patients are so busy, forcing themselves to hold up straight. Just kind of relax into it. So if you see the muscles really sticking out on one side, it's probably a rotation to that side. The transverse processes will push the muscles out. Okay, so you identified one that's deeper. Would we say that's like L2? Let's just give it a name.
Yeah, L3, L2. Sure.
Okay, so that's L2, say. Now, slump, bring your head forward, bend forward with your body. Bend, 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 bend. You can lean on your hands if you want. What happened with that? Did they stay asymmetrical or become symmetrical?
They became symmetrical.
Okay, so he was prominent on the right before, but now it's symmetrical.
Right.
So shouldn't they be both deep in flexion? So they're in their happy place. They're in their dysfunction. So it's a flexion dysfunction because it corrects in flexion. He's happy there. But when he's neutral, prominent on the right. So he's rotated right. So it's a neutral dysfunction. In neutral, side bending and rotation occur to opposite sides. So if he's rotated to the right, which way will he automatically be side bent? If he's flexed, his right facet joint is stuck open. Won't extend. If it's stuck open, not going to be able to close, not going to be able to extend. What happens if he extends?
Go ahead and extend.
Just slump kind of like this way. Sometimes I just give him a little push, let that, yeah.
It's prominent. The right side is prominent.
So the right side is more prominent again.
Yes.
Okay, so it corrected completely in flexion,
Okay.
but the right side is prominent in extension. Did you notice if it was several vertebrae or just one?
Looking at this, it looks like it's
Several.
So it's several.
Okay, so if it's several,
It felt like one.
which dysfunction is it, type 1 or type 2?
One.
Be the lumbar vertebrae. Make your hands a facet joint. Okay, when they flex, where does it go? Forward. The transverse processes go deep. They go anterior. When they extend, goes backward, closes, becomes more prominent. Okay, if you're side bending to the left, the right facets open and the left facets close. So just get a sense of how those spinal mechanics move. There's some joints coming around that you could palpate to see, but that's basically, you have all of this here repeatedly in your book. Okay, so to name the dysfunction, you're going to state the position that the joint is held in. Neutral, side bending right, rotated left. So you palpate it in neutral. They're side bent to the right, and they're rotated left. If it helps you to actually stand up and go through this little dance, feel free to do that. So the motions occur in opposite direction. What if it's FRS left? That means that vertebrae, say we're talking about L3 on L4. L3 is FRS left, flexed, rotated, and side bent left. So L3, it's flexed, it's rotated, and side bent to the left. It really helps if you move your body and feel it. This is non-neutral. The motions are coupled in the same direction. If they're ERS, these are the terminologies we use these in our notes, extended, rotated, and side bent left. So ERS left, say L3 and L4. L3 is extended, it's rotated, and side bent to the left. So which side is open and which side is closed? Left is closed, right is open. Okay, so palpating, we practice a little bit with that. The palpation, I just like to do this on all different body types, athletes, older people, younger people, people who are very thin, people who are very thick. If you have a patient who's morbidly obese, it is nearly impossible to palpate some of this. There's going to be a limitation there. I might choose to use a different technique, or really notice, does one side of paraspinals really bulge compared to another? Maybe I have my football linebacker on the table and you really see those muscles. Do you see that bulging? So don't try to read into it or imagine it there. Either it's obvious or it's not. If it's not obvious, try something else. Again, the palpation is questionable. So facets open into flexion, the transverse processes go deep. Just get that squared away in your head. Facet joints close in extension, so the transverse processes become more prominent. So anytime you see the transverse process more prominent on one side, that means either the side it's prominent on is extended, or the side it's deep on is what? Flexed. And you have to test. Is it neutral or non-neutral? An extension dysfunction, something stuck in extension, will be symmetrical in extension and asymmetrical in flexion because it doesn't flex on that side. A flexion dysfunction will be symmetrical in flexion, its happy place, I call it, and asymmetrical in extension. Because it's flexed, it won't close and extend. You see? Try to get a picture of that in your mind. Now, I'll just go back to that again. If I had you doing sitting for the palpation of neutral flexion or extension, that's fine. But typically, we're treating a patient on the table. So for neutral, I palpate them in prone for neutral lumbar lordosis. I'll have them extend by propping up on their elbows. Some people call that the Sphinx position or prone prop puppy position. You'll see that terminology used in your book, the prone propping. I find it's confusing to say we're extending them without saying, what are you extending? We're extending the lumbar spine. Later we're talking about the sacrum. Well, extending the sacrum is very different than flexing the lumbar spine. They're actually moving in opposite directions. So always named by the vertebra that's moving, the superior vertebra over the inferior vertebra. L3 is moving on L4. L3 is FRS left. It's flexed, rotated, side bent left. Relative to L4, so always picturing what you're looking at. Sacrum, obviously, totally different animal. Okay, so you could palpate for someone. If you wanted to keep them on the table the whole time, neutral, just prone, propped up like a sphinx in extension to check your extension. Flexion, I could just have them go, on their hands and knees. If you didn't want them to have to hop on and off the table, you could look at flexion that way, compare. So palpation is just saying the same thing again for you. I gave you a little table of the same thing again. If you just take a moment to stick that in your brain and remember, it'll make the rest of the day easier. And you can keep those out. Let's look at type 2, single vertebrae. Again, this is repeating the same information. Rotation and side bending occurring in the same direction. If you find only one TP in neutral, okay, that's a different problem. Type 2 flexion dysfunction. Let's look at an FRS right. Okay, you have a single prominent transverse process in extension. If you found that asymmetry in extension, either it's a flexion dysfunction on the opposite side of the prominent transverse process, or check the motion. It could be a flexion dysfunction on the other side. So what do we have? Right transverse process is prominent in extension. Say they're all symmetrical or asymmetrical neutral. We're really looking at extension. So right transverse process is prominent in extension. That means either the right's extended or the left is flexed. If they're flexed, rotated, and side bent to the right, what happens? they're flexed, there's a flexion dysfunction, they're all happy in flexion, everything's symmetrical in flexion. But when you extend them, FRS right, it's flexed on the right, it fails to extend on the right. So it stays deep in flexion when they extend. So which transverse process will be prominent? The left. So you're going to go by palpation on that, okay? Left facet is stuck open in flexion, it can't close. So going to be a problem there. Palpate, flexion, there's symmetrical, extension, there's one transverse process prominent. One of the general rules, which frankly I don't always follow, but this is listed in the osteopathic literature, that you treat the non-neutral, the type 2, the FRS, the ERS first. They feel it will correct better if you do those first. I haven't really tested to see if there's a difference what you correct first, but that's what's in the literature. So if they're ERS or FRS and they have some other dysfunction like a sacral dysfunction or a group dysfunction, you correct that single vertebral dysfunction first. If they're extended, rotated, and side bent left, and that's the position they're stuck in, what position you want them to go to? Flexed, side bent, and rotate right. So it's just the opposite direction. The opposite direction is the position of treatment. If they're extended, we're going to flex them. If they're rotated to the left, we're going to rotate them to the right. If they're side bent to the left, we're going to side bend them to the right. Now, because these motions occur together, rotation and side bending, couldn't I use just side bending to correct it? Since rotation will automatically happen? You think that might work? You don't have to correct everything at once. Moving, correcting in one direction will correct the other directions because they occur together. So when we get a patient on the table, we see, well, they're rotated and side bent, we only have to correct the side bending if we're dealing with a neutral dysfunction. Some of them will combine. So depending upon whether you're looking at Mitchell's muscle energy, a physical therapist named Tom Oakler looks mostly at three-planar muscle energy. Sharon Weiselfish, I have one of her books up there. She separates neutral and non-neutral into, well, some you correct only one plane, some you correct all three. Because the literature says different things, decide on your patient. I look and I see what's most dysfunctional on the patient. That's what I'm going to correct. And you'll be able to start figuring it out as you see where they are. If they're stuck on the left, side bent left, you're obviously going to want to contract them to go to side bent right. Okay, so say we start with ERS right. They're extended, they're side bent, they're rotated right. They're extended on the right, so the facet is open or closed on the right? Closed. If they're closed on the right, what are they on the left relatively? They're able to open. So which position on the patient with your palpation will you find this dysfunction in? They're happy in extension, so where will it show up? In flexion, okay? Because it's the opposite of their happy face. So rotation and side bending occur to the same side. So we're going to correct them to the same side, okay? When you're measuring the patient, when you first start doing your gross range of motion, if they're extended, side bent and rotated to the right, what motion are they going to have trouble doing? Just on your gross goniometry. They're going to have trouble with forward bending, side bending to the right, and rotation to the right. So that's something you might have noticed on your gross testing that tells you go and palpate the vertebrae and see, is it a group of vertebrae or a single vertebrae, what's stuck. But your goniometry of your general palpation may change. You might find they flex more. Oh, before they can only reach their fingers 17 inches from the floor, and after I did the correction, oh look, now they're 15 inches from the floor. Okay, this type of thing could change. People keep it, well, what's going to change before and after? The palpation is what we should see change, but the literature says that that's not reliable. So look to see if your other ranges of motion changes. So again, diagnosis, if it's extended side bend, rotated right, we want to flex them. We want to side bend them to the opposite side, left, FRS left. This is just a little cheat sheet that I gave you that has everything on it. I'm not going to go into everything because I've said most of this already, but it kind of tells you if they're flexed in a dysfunction or extended in a dysfunction, where you're going to see the prominent transverse process, where the direction of rotation is, what position you identify it in, etc. It's all there. So if you were to use a master sheet, I would dog ear that page and refer to it and when you're going through the practice, because I'm just going to show you a single example of each one of these. You're going to pretend that your patient has the dysfunction I'm showing you, go through the motions, and see if you could fix it. We're going to start with a neutral dysfunction. All right, so now we're getting into what's the actual intervention to correct what you found. Say you palpated on a patient in neutral. A whole series, multiple segments of prominent transverse processes on the left side in neutral. What happens? You find that if they're prominent in neutral, what happens? What are they in neutral there? Okay, so the neutral, side bent right, rotated left. We're just going to pay attention to the side bent right aspect. If there's a bunch of transverse processes prominent on the left side, you know if they rotate left, those are going to be prominent, correct? Everybody understands that? And rotation left is the front of the body faces left. So if I am the vertebrae, it's going this way. The bunch of left transverse processes prominent on the left in neutral. By your Fryet's-Boot rules of biomechanics, if it's neutral and it's type 1, side bending and rotation occur to opposite sides. If it's type 2, side bending rotation occur to the same side. So this is neutral. So it's going to be opposite sides. So that means if they're rotated left, because you palpated all those prominent transverse processes sticking out on the left side, they're rotated left. They're automatically side bent which way? According to the law, to the right. So which way to correct it? If they're side bent right, what direction do you stretch them? Side bend them to the left. If you identified the problem in neutral, you correct it in neutral. That's the first thing. If you identified the problem, that's type 1. If you identified the problem type 2 in flexion or extension, you're going to treat them in flexion or extension. So that's the first rule. So they're neutral, they're side bent right. We want to side bend them to the left. So I'll have the patient on the table, scoot a little closer to me. Make sure he's close enough to me they don't have to reach over because he's going to be lifting his legs, and that might be heavy for some patients. Palpate here. How do I palpate? I palpated first before when he was sitting or standing or lying, but now he's side lying. Find the iliac crest. Come right across from there. The spinous process is L4. Say I discovered, oh, it was L3 that was side bent. So I'm going to come one above. I'm palpating that vertebra here. Come a little bit. It was prominent on the left, so the transverse processes, I should feel prominent, make believe, on the left side here. The most prominent one was L3, although I found it L2, L3, L4, L5, all side bent. Find the apex of that curve, palpate. Now, I'm going to see, I want to keep him in neutral, but I want to be able to side bend him. When I lay him on the table this way, automatically, which way does his lumbar spine side bend? To the left. So I'm already partly correcting. So what can we do here? If I want to side bend him to the left to correct it, if I lift up from his feet, palpate, as I'm lifting, you see the iliac crest starting to move? Am I side bending him? To the left? See? Now, how do I know when I get to that vertebrae that's in dysfunction? I have to palpate. As I lift, just rest, you don't have to do it for me. Sometimes I'll kind of lean the knees into the front of my hips so I have a good purchase on his legs. Keep them together, side bend. I get no movement. Oh, right here. Can you feel that this starts to move here? Yeah. Patient can feel it too. And I'll often tune the patient in. Oh, can you feel that move right there? So he gets a little more proprioceptive input in his body. So now I have come to the level of the barrier. And if we're doing our post-isometric relaxation or autogenic inhibition, which way will I have him push his feet? I'll resist side bending to the right. Push your feet down to the floor lightly. Hold it, like give me a pound. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Good, relax. So I resisted side bend right. Now I go to my new barrier. I should be able to feel I can move him more before this moves again. That's my new barrier. You feel a little stretch when I'm doing that? Mm-hmm. You okay with the hips and knees?
Yeah.
Okay, always check in because some people have problems with the knees. Obviously, you can't do that and torsion through the knees this way. Push your feet down to the floor. Again, I'm using a long lever to resist side bending right. And as it holds out a few seconds with about a pound of pressure, relax. Breathing for me. Side bend more to the next barrier. Now I can feel it pulling. You feel how it's a little different at that angle? You got a little bit more pull. And hold that. So 3 to 5 reps. So basically, resist the motion that they're stuck in. Side bending right. Push your feet down to the floor. Good. Hold it. 2, 3, 4, 5. Relax. As he relaxes, then I go into the new barrier. Side bending to the left. And that's all you have to correct is get him to go into side bending left. It'll automatically correct the rotation. So the neutral is the easiest to correct. Now, you can use any position you want as long as you achieve the left side bending, and you can isolate the apex of the curve, say, which would be, in this case, if the curve is L1 to L5, it's at L3. So put them on their side, right side. If you put the concave side of the curve down on the table, the right side is the concave side, they automatically side bend to the opposite side. So that's why we're doing this. It's just how you position them. So if they're laying on their right side, you automatically created some left side bending. Palpate the apex of the curve. Find L3, palpate L3. Bend their hips and knees just to a level where the spine is still in neutral. So if you flex them up too much, you're going to take them out of neutral. You want them neutral relative to flexion extension. Now, put their knees against your body, depending on how tall you are. It might be your belly, it might be your hip. Okay, it's easy, of course, if you have a table height that's appropriate for you. Grab their ankles with the feet together. Lift the feet up. As you lift the feet up, notice when they start to side bend under your palpating finger at L3. Feel when they start to side bend at L3. Try it a couple times, go up and down with the feet until you get a sense of when can I palpate the movement, start and stop at L3 under my fingertip. Take a moment to practice just lifting and lowering the legs so you feel, when does that vertebra move? When does it stop moving in lock? You want to lock it into place. It's easier if the knees are off the table. It's really your personal comfort, how long your arms are, how tall you are or short you are. Comfort for you. Lift them up until you feel that vertebrae lock into place, and then you're going to commence with your muscle energy contraction. Tell them, push your feet toward the floor. Do not allow them to move. Give me 1 pound of pressure. Push your feet down to the floor. You're resisting right side bending. Push your feet down to the floor. You're resisting right side bending. The tight, short right side bender muscles are contracting as they relax. Relax and breathe. Lift the feet up higher. Side bend them more to the left. Side bend them into the barrier. Create left side bending.
Are you palpating?
Palpate the apex of the curve. You could palpate the spinous process, is a lot easier. Yeah, it's easiest to palpate the spinous process when you're doing this. Some people palpate the transverse process. I've seen it written both ways. You could even take a finger on the spinous process and a finger on the transverse and feel both at the same time. You palpate with 2 fingers. So that might make it a little bit easier for you. So resist the motion. Push your feet to the floor. Resist right side bending. Relax, lift the feet up higher to create a moment of side bending to the left. Have the patient right up against the edge of the table right next to you. I'll often feel like I'm almost hugging the patient against my body, so I have a good purchase on the patient. They're not going to fall. I'll often put their knees into my hip or thighs against my hip, so I'm supporting them so they're not falling down. If you're not fully supporting them, they're going to be guarding, and it's not going to work. If someone's flexed, rotated, and side bent left, to correct it, you have to put them in the opposite direction. Extend, side bend, and rotate them to the right. How do you know that they have FRS left? Okay. If they're a flexion somatic dysfunction, they're going to be symmetrical in flexion, their happy place. So it's almost like you name it by the happy place. If they're stuck in flexion, it's a flexion somatic dysfunction, FRS. How do you know if it's right or left? Okay. The transverse process will be prominent. A single transverse process will be prominent. We're using this example of L3, and we'll say L3's transverse process on the left is prominent, just a single. The last one we looked at, a bunch was prominent. That's a neutral dysfunction. This is prominent on the left when they're extended. So flexion dysfunction is going to be symmetrical in flexion and crooked in extension. Okay. So as you put them in flexion, they're fine. You have them prone, prop up on their elbows. You palpate. L3 transverse process prominent on the left. So if they're prominent on the left, which way are they rotated? Left. The transverse process always sticks out on the side they're rotated to. So opposite, which direction do you want to move them? To the right. Okay? So you're always going to correct it by moving them in the opposite direction. What you want to see here too, if you find the prominent transverse process in extension, it's a facet dysfunction of the opposite side. Because in flexion dysfunctions, they're stuck open. In extension dysfunctions, they're stuck closed. This is a flexion dysfunction. So when you put them in flexion, instead of both transverse processes going deep, starts to go deep, and what happens? It rotates and side bends to the left, because when the facet joint fails to close on the right, what happens? It's stuck in the open position. They're going to side bend. So they're rotated and side bent to the left. You put them on the left side to kind of side bend them to the right, correct? Okay. How can you extend them? They're flexed, you want to extend them. So palpate L3 with one hand. Now when you palpate, you might want the index and middle finger to be your palpating fingers. Put one finger on the spinous process, one finger on the transverse process. Do it step by step with me. This way you can monitor that vertebrae. Now if you have the top leg up about 90 degrees or so of hip flexion, stabilize the leg against your body so they don't fly away. Okay, lean it against your body because you're going to need your hand. You can't be holding the leg up with your hand. You have to lean it against your body. So the top leg, jam it against your body so it frees up your hand. You need your hand to extend the lower leg. We're getting the spinal lumbar extension by extending the lower leg, the leg that's on the table. So extend it until you feel the barrier under your fingers. Extend, palpate that L3, say. Extend until you feel it move. That's it. Practice extending that lower leg until you palpate that L3 stops moving. This is just like we did before using the two legs, but we're doing extension. It's a flexion dysfunction. You want to correct it by extending them. Extend the bottom leg to the barrier. Now we're going to use two more motions. We're going to rotate them to the right because they're FRS left. We want to rotate them to the right. Take their right shoulder, their right thorax, push it back to rotate them to the right. But only to the barrier. So you have to palpate L3 to see where that rotation barrier is. You locked in the extension barrier. Now you have to lock in the rotation barrier. So you got your extension barrier. Once you're there, you leave the leg there. Now, you could use either your elbow or your other hand to drop the shoulder back on the right. You could also ask the patient, turn your body back toward the table, look over your right shoulder to make them rotate to the right. So good, drop that arm back behind you too. They could even reach their arm back behind them. They could reach their right arm back behind them. There's like 20 ways to get them to right rotate. The easiest way, look right and reach over your right shoulder. That will create a right rotation. They can help you. Okay, we're moving into the last of these flexion extension somatic dysfunctions, or type 2 side bending rotation occur to the same side dysfunctions. ERS right. So now we're looking at someone who is extended, rotated, and side bent to the right. What are we going to do to correct it? Flex them, rotate and side bend them to the left. Okay, if they're in an extension dysfunction, their happy place is where? Extension. So you're going to see the asymmetry in flexion. So if you're palpating someone, if you want to get someone on the table again and feel through it as I talk to you, why don't you go ahead, switch partners, have the other partner who went second go first now. Now, in order to get them to flex, they have to kind of go on their hands and knees and flex forward and take a bow. So tell them, go on your hands and knees and flex forward like you're taking a bow. Now pretend you find one right transverse process at L3 prominent when they're flexed. Remember, when the spine is flexed, the transverse processes are supposed to go deep and symmetrical. The right one failed to go deep and symmetrical. Therefore, it is stuck closed. It is stuck in extension. Therefore, it is an extension somatic dysfunction. It's symmetrical in extension. It's crooked in flexion. The right transverse process failed to go deep when they flexed. Okay, so it's extension, rotation, side bending, dysfunction to the right. Side bending and rotation occur to the same side. So extension, rotation, side bending right. What do we want to do to correct it? We want to flex them, rotate them to the left, and side bend them to the left. So how can you side bend them to the left? What did we do to side bend somebody to the left before? How did we position them? Lying on the right side. So go ahead, put your patient on the right side. Palpate the imaginary L3. Okay, they're ERS right or stuck in extension, rotation, and side bending right. If we put them on their right side, we automatically started side bending them to the left, didn't we? So we started our correction. But they're extended, we want to flex them. How can you flex them? Pull those knees up, flex the hips to flex the back, right to that L3 barrier. So palpate L3 with your top hand, the hand that's more cephalad. Flex the knees up together until you feel motion at L3. Good. If you lean the knees against your body, against your belly or your hip, you can hold their legs without having to use your hand to hold their legs. Play with that. Again, table height will be a difference for different height people. Hike that into, yeah, put your foot. Got a book in the way, put your foot up. If you're standing on a stool and the table's too high, that will help to stand on a stool. If you're tall, you got to bend your knees. It's really a matter of size difference. So does everyone have the person flexed up to the barrier? Good. Now you want to think about, okay, how about the side bending there? Going into side bending left is what you want. So drop those feet toward the floor. Make sure you're holding the person so they don't fall down. Drop those feet to the floor until you feel the barrier of side bending. When you reach the barrier, have them push your feet up toward the ceiling. Push up to the ceiling. Hold it. Don't let them move. It's isometric. 5 seconds hold, relax, and then gently down with the feet into the new barrier. So you're side bending them to the opposite side. So you're lowering the feet to the floor to side bend them more. Now, how do you do the rotation? Ask the patient, you want their rotated left, you want to rotate them to the right. That means you want them to turn the thorax to the right, so tell them, hang your arm in front of your body, reach it toward the floor off the table. So he's going to reach forward. If you can't move him with your elbow of your palpating hand, ask him to reach himself. He could do it actively. Good. Wait till you feel the barrier. And then have him contract again. push the feet up, hold it, hold it, hold it, relax. Now as I push the feet down, I get more side bending. She could easily pull her elbow forward on the back of his trunk to get more right rotation. You have your arm leaning against their back. This is an extension dysfunction. You want to flex them.
Right side.
Say she's extended. We'll just pick a bone.
Okay.
Flex her up to the
I
dysfunction.
get the play out.
Now, you could use two different things. You could use post-isometric relaxation, which is autogenic inhibition, or you could use reciprocal inhibition. There's actually two methods you could use, because some people will drop the feet down and some people will bring the feet up. Incidentally, both will work.
Because they're opposite directions. Though.
Yeah. Okay, so say for instance, if I dropped her feet down, which way is her trunk side bending?
Now she's saying right to the right.
To the right.
Yeah, but don't we want to side bend left?
Okay, side bend to left, she's going to push her feet up.
Okay.
Okay, so if she's ERS right, her right side benders are too hypertonic.
Okay.
So if I want to stretch them, I could either contract the right side benders,
Okay.
okay, and then follow it with a stretch,
Okay.
or I could contract the left side benders and have her actively help me into the position.
Okay.
Both directions will work.
Okay. You
So,
could passively just take her into it.
so she's ERS right, so
And then you have to work against you. So
this will make her more left side bend, but I'm contracting, push your feet down to the floor to contract, say, the right QL. And as she relaxes,
I guess that one makes more sense to me.
I have her side bend left more.
Yeah.
Push your feet down to the floor
I get that one better.
as she relaxes. But depending on the patient, some people I might have found the barrier here, someone else I'd find the barrier here, someone else I'd find the barrier here. So I'm going to feel where in this range is her barrier.
Okay.
So as I'm coming here, this is moving, 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 moving. She's moving pretty freely. I don't feel this change until do you feel that difference here? I don't feel a change until I get here with
So
her.
the reason you just let them go and drop them is to just let her body just do it.
Yeah, you could either let her do it as a stretch or as a contraction.
Okay.
Either one.
Got it.
Sometimes I'll do a little of both.
So then what about the rotation?
The rotation component, say this was the side bending component. If I want her to rotate also, I was just addressing side bending because that was your question.
Right, right,
This would be rotation right.
right.
If it was that I wanted to cause left rotation, it would be this way. So depending on which dysfunction she had,
So this one.
one way or the other.
The dysfunction is right. So we'd want to go into.
ERS right, I have to keep looking because
I know.
I'll say the wrong thing unless I look at it.
We gotta keep
So
saying
she's ERS right,
you want to be this way.
so I want her to F,
Yep. F.
R left,
Yep. And R.
S left.
Yes. Okay. That makes sense.
Yeah.
I guess when you drop.
But
her down,
I could have put her on her other side of her body and twisted her the other way.
That makes
So it depends on which side of the body I
that's
put her
what
on.
confusing when you went down. You're like, oh, that's
I put the other person on their other side of their body,
I see,
and that's why
exactly.
that was confusing to you.
Exactly.
So going to look at some examination techniques to see, can we identify that the sacroiliac joint or the iliosacral joint, just for the sake of keeping it easy in the class, I'm just going to call it SI joint. Whether it's the ilium moving on the sacrum or the sacrum moving on the ilium and getting everybody confused with nomenclature, it's the SI joint. Is that good for everybody? So we're calling iliosacral somatic dysfunction. What happens if the sacroiliac joint gets stuck or locked? There's all kinds of movements of the sacrum across all different axes, and what's even most fascinating about this is some of the axes are imaginary. Some of them are real. There are 3 real documented axes of motion, and some are, shall we say, imaginary. Some people will say that the joint, that is what we call the SI joint, has all different facets on it, and the kind of facets or connections between the ilium and the sacrum are different on everyone. So one of the reasons that what you see in the research is so varied is that people actually have, when they do cadaver dissection, they studied this, people have different shapes of sacroiliac joints. So it's not like a nice ball and socket, like the hip joint or the shoulder joint, you know, a cup and a ball. Its articulation is very odd. Some people will come out and say that the sacrum actually does not move on the ilium at all. How many people have learned that somewhere along the line? It's stuck, it's not moving. Orthopedists I used to work closely with said, that joint doesn't move. So I said, well, if you get on the table, I could try it. No, he wouldn't get on the table and let me show him. So that told me something right there. If you study anatomy on dead people, it doesn't move. If you study anatomy on live people, it does move. They have done new studies with MRIs, X-rays, looking at how much motion is available at the sacroiliac joint, and it shows from, some studies will say like 2 or 3 degrees. I've seen other studies say 5 to 8 degrees. Again, how they did the study, how they measured might have been different. So we have quite a bit of conflict in this area in the literature. I'm going back to what I said this morning. If there's conflict in the literature, if I'm using an intervention based on whatever examination techniques I'm discussing with you here today, if I'm getting a functional, measurable change on my patient, on my treatment table today, I'm good to go using the technique. If not, we need to have more research to show how we could better palpate, how we could better document motion at these joints. And the bottom line is, if your mother delivered you with a natural childbirth and that SIJ joint didn't move, would you be here today? You'd probably still be stuck up in there. That would be a problem. Okay, so that's one thing we have to think about. And most physicians will readily acquiesce that yes, obviously when there's relaxin hormones circulating in a pregnant woman, it's going to loosen up the joints, so now all of a sudden it'll move. But if the joint was fused, what would be in the joint? Bone, just like the cranium. The cranial sutures are fused, what would be in the joints? Bone. What's shown on both microscopy, electron microscopy, as well as on dissection under a light microscope, connective tissue. Whether it's a SI joint or the cranium. You're not going to find connective tissue in a joint and nerve endings and blood vessels if it's fused. Not like that. So we're taking it from common anatomy now, and if you want some resources on that. I also brought with me just a couple of the articles of some of this conflict. Assessing the sacroiliac joint, the best test for SI joint pain. You've got, that's physical therapy literature. Chiropractors like to jump in on it too. There's different commentary, Journal of the Canadian Chiropractic Association. Anybody know French? I didn't realize till after I downloaded it. It's in French. The abstract is in English, but feel free to look at it. There's a lot of controversy about what are we measuring and is it really happening. So since there's a lot of controversy, we're just going to assume that it's moving today. We're going to assume that we are doing decent palpation to see if things change or not. And the bottom line is when we're all done assuming, because you know what happens when you assume, you're going to do a functional test pre and post treatment to make sure you made a change. Because that's something the functional tests have been shown to be valid and reliable in the literature. If you don't know where to get those functional outcome measures, you can just go to something like Google Scholar Online and put in functional outcome measures for back, sacroiliac joint, shoulder, whatever body part you're looking for. There's also a really good reference, couple of them. One is named Carol Lewis, Lewis, if you want to write her name down. She does a free article in the Physical Therapy Advance. Anybody get the Advance? It's all free. You don't have to pay for this stuff. And she outlines a different functional outcome measure every week. So I find that really helpful, particularly for when patients want to get reimbursed for their work or you want to get paid for what you're doing. Functional outcome measures make a difference. She has an exhaustive amount of stuff online that you could get for free and look at. Another person, Therese McInerney, actually used to be partnered up with Carol Lewis years ago. They wrote a book called The Functional Toolbox. Carol Lewis has updated it. Now there's a Functional Toolbox 1 and 2, and it has a compendium of all different functional outcome measures. I bought the books because it was useful in my practice. I could literally open a 3-ring binder, pull out a functional outcome measure like the Neck Disability Index, the Back Disability Index, the McGill Pain Inventory Questionnaire, or whatever index I'm looking for, throw it on my copy machine, give the questionnaire to a patient, or some of the tests you have to actually do something like Dynamic Gait Index. You have to progress through a series of things a patient does walking and stepping around obstacles, and you get scores for these things. And those hold up very nicely in liability cases. They hold up nicely in court, and particularly for insurance reimbursements. So again, I'm making sure, do your functional outcome measures, and pre and post treatment for ones that are appropriate for the same day. For ones where the functional outcome means they have to go back and try doing functions of everyday living at their job or at their home, you might do that maybe once every week or two and see a difference. Have you guys been using those outcome measures so far? Yeah, check those because the other stuff is unreliable. But you have things here, like here's one, physical therapy, 4 clinical tests of sacroiliac dysfunction. The association of test results with a nominate torsion. Some people say that the pelvis twists and some people say it doesn't. I've seen a lot of pelvic torsions and I've corrected a lot, made huge differences in people's function. If this didn't exist, obviously their function wouldn't have changed. So take a look at some of those when you do get a chance and you'll see what's out there. There are many studies, newer studies now, on sensitivity and specificity of these tests, and people are getting all involved in that. Like I notice when I'm going to new courses on differential diagnosis for lumbar, spine, and sacrum, the courses I've been to, that's all they talked about is specificity and selectivity and sensitivity. Does this test actually measure what we're looking at? Is there really a difference in the patient in terms of a minimally clinically important difference? That's all fine. Here we're going to let that go. I have that available if you want to look at it, but here we're looking again at technique. So if you have questions on that, I can certainly help you, or you also have in the handout, you should have my email address in there somewhere, edgesize@yahoo, or my website, edgesize.com, is right in the first slide, the title slide. If you have questions after you leave, even later, email me your question, and I'll be happy to tell you, oh, I got that resource from whatever, or help you with a patient problem if you have a question. So we're looking at, can we test motions where the sacrum is fixed, and we're looking at motions of the ilium. Some exams we do, okay, the ilia fixed, we're looking at motions of the sacrum. It's just like any other joint. You're fixating proximally and moving distally. So you have to just identify what part is moving. In these iliosacral somatic dysfunctions, we're looking at a couple of different things. What's crooked around the pelvis? Does it look like the pelvis is elevated on one side? Maybe it's an upslip, or maybe it's a downslip on the other side. If you're palpating the pubic bones, does it look like one pube is higher than another? So an elevated or a descended pube. Typically those go together, sometimes they don't. What about a rotation? What kind of rotation is this in the pelvis? What kind of pelvic tilt is that? That's elegant, right? Anterior pelvic tilt, would we say? Or anterior torsion. So what muscles are tight? Hip flexors and spinal extensors. So didn't we do muscle energy already this morning that might help correct that? We did the Thomas test, right? We found out the hip flexors were short. We did some muscle energy to increase hip extension. So you already know something that we could do with that. How about the person who has the flat back with the tuck, posterior pelvic tilt? What muscles might be tight there? What attaches the ischial tuberosity might be pulling it down? Hamstrings. So you already know from what we did this morning, you know how to stretch the hamstrings. Perhaps if that person has that type of a torsion or rotation, you might correct it. So we're always correcting the opposite direction of the fixated position. I think, is that clear from this morning? They're stuck flexed, we're extending them. That's it. And that's called direct technique, by the way. Direct technique in osteopathic medicine, you move against the barrier. Something stuck, you make it move. You manipulate it, you stretch it. Indirect technique moves in the directions of ease. So there's other techniques for that that work very well as well. So here we're looking at pelvic asymmetries. In flares, out flares. If I can have a spine, let's get one of those spine models. With an in flare, if you're palpating, and we'll have you guys palpate these in a little while too, ASIS, anterior superior iliac spine. Everyone feel that in the front of your hip? Right at the crease where your hip bends, just a finger width above it, you'll feel that bony prominence, ASIS. You'll palpate that on yourself. When you're palpating the ASIS, one of the reasons that people disagree on their palpation is that the ASIS on this person goes from here to here. It's about almost an inch long. So one therapist comes along, palpates the superior pole. Another therapist comes along, palpates the inferior aspect of the bony prominence. Someone else, just for good measure, palpate right in the middle. So why do people disagree on these heights of these landmarks? They're not all palpating the same place. For the purpose of palpation today, when we're identifying a bony landmark, we're going to put our fingers, our thumbs, a middle finger, whatever finger you want to palpate with, under the bony prominence. Come from its most inferior aspect. It's like it's on a little shelf. Make your finger a shelf and put that bony landmark above it so you can feel it distinctly. When you're looking at these landmarks, use your dominant eye, which means, now I say my right eye is dominant. Here's your landmarks, put your thumbs there, put your dominant eye right in the middle of the landmarks. If I'm looking with two eyes, there's motion parallax. If I'm looking from the side, will I be accurate in how I'm viewing these bony landmarks? No. So you have to have your dominant eye right smack in the middle. If I'm looking at someone's pelvis, and say the patient is this tall and they're standing like this, if I'm looking from up here, will I get a good view? Shouldn't I have my dominant eye right there, level with the landmark? So these are all ways that you may be able to possibly make your palpation more reliable, okay? Intra-rater reliability, reliable for yourself. So do check that out. You should be able to palpate ASIS, PSIS, posterior superior iliac spine. Again, this is a big bony prominence. You're going to come from below it. Make your finger like a little shelf and have that bony prominence above it. Iliac crest, we looked at that this morning. Put your hand in from the narrowest part of the waist, and if you push down with the web space between your thumb and index finger, iliac crest is right there. So you can compare iliac crest heights. And the other things you'll look at on the pelvis is ischial tuberosity. The sit bones, what most of you are sitting on right now. So when you're dealing with the pelvis, for some people, this is a socially very private area. Patients don't always enjoy you poking at them in the rear or around the pubes of the pelvis. So you educate the patient before you start. There are muscles that attach to certain bones around your pelvis. I need to see exactly how much mobility you have in your joints to figure out why you have this pain or this problem, whatever the dysfunction is they have. So I get permission from the patient and I let them know. Sometimes I'll have the patient palpate their own landmark so that they can feel where it is, and then I'll put my finger over theirs. So depending on how personal someone is, educate them, because if you don't access these landmarks, pubic tubercles are a perfect example. Very private area here around the perineum. So when you palpate, you don't go in the middle first, on top. It's easiest if you come in over the patient's belly, where it's the soft, feel it on yourself, the soft part of the belly, between your umbilicus and the top of the pubis. Okay, soft part of the belly. If I very softly push in on the belly and slide my hand down, my ulnar border of my hand comes right to that bony shelf of the pubis. It's a lot less invasive to a patient if you come in with the flat part of your hand above the perineum. Then once you feel that, then you know those pubic tubercles are going to be just bilaterally about a finger width or two lateral to the midline. So it gives you a nice way to palpate, okay? Those are nice ways to approach on a patient. When we're looking at these iliosacral dysfunctions, pelvic inflares will be when it seems like an ASIS, ilium on one side, is more medial than the ASIS on the other side. An outflare would be when the ASIS on one side appears to be more lateral. There's more space between the midline and that ASIS. Now what do you call it? If the right ASIS is inflared and the left ASIS is outflared, which one's which? Which one's stuck? Well, we'll do a bunch of tests of sacroiliac joint mobility, flexion tests, squish tests, different mobility tests. It's named by the side of hypomobility. Or again, it's named by the side that's stuck. So if you see, oh, it looks like an inflare on the right and an outflare on the left. Which SI joint is stuck? If the right SI joint is hypomobile and stuck, we call it a right inflare. If the left SI joint is the one that's hypomobile and stuck, we're going to call it a left outflare. Because how do you know how many inches or centimeters that ASIS should be from the midline? Everybody's different. How about a woman's pelvis compared to a man? Farther away from midline, we have a wider pelvis to be able to accommodate a baby, perhaps. Okay, men have narrower pelvis. So we're looking at inflares and outflares. There'll be a specific treatment to correct each of those. Rotations. This one, any of the spine models we have actually move, or are they all stuck? If you have one, could you just pick it up and tell me if the pelvis moves or not, or is it fixated? Well, fixated. Okay, so rotations. We mentioned an anterior pelvic tilt, an anterior rotation, posterior pelvic tilt. Look, I lost 10 pounds, right, doing the posterior pelvic tilt. Or posterior rotation, so anterior, posterior. Often one side will be anterior. Does that one move? Great, thanks. The left side will be posterior. So just to exaggerate, it doesn't move this much. Anterior, posterior. If the SI joint becomes torsion like this, they might have pain. Could be in one SI joint or the other. I haven't seen it necessarily follow a pattern of which one's going to actually hurt. So anterior rotation on the right. Right ASIS is inferior, left ASIS is superior. The whole thing rotates. If it's rotating forward, what's coming up? Anterior rotation on the right. Right ASIS is inferior, right PSIS is superior, anteriorly rotated. Relatively, the left ilia looks like it's posteriorly rotated, doesn't it? How do you know what to name it? If I did a sacroiliac mobility test and I found out that the right side was locked, it's an anterior right innominate. If I found out that the left SI joint was the one that was locked, it's a left posterior innominate. So is that clear in how we label it? Everything is relative to the other, but we're labeling it by the stuck side. Okay, these pelvic in-flares, out-flares, and rotations, these are motions that occur during normal everyday movements like walking. Your pelvis tends to flare in and out a little bit. It rotates forward and backward a little bit. So we would say they're normal motions. But if it's very asymmetrical, it could be exaggerated. And that's what we're looking to correct, a dysfunction. That dysfunction of throwing off the pelvis, again, because this is the center of gravity, might throw off their balance. It could throw off their gait in terms of their step length, their stride length. These are easy things you could check. And in someone who's more involved, I use an example of like the timed up and go test or a dynamic gait index, things you could test as a functional outcome measure to see did it make a difference. Now there's something else that occurs here, and that would be, this is for the hypomobile side. Oh, let me mention before we move on here. Decide the hypomobile side by our sacroiliac mobility test that you're about to do shortly, okay? However, no single test, I'm going to give you a bunch of tests, no single test is reliable. I have certain tests that are my favorite, and I was really surprised to see in the literature that none of them have been shown to be reproducible or reliable, and many of them have very low specificity or sensitivity to actually point out what's really wrong. So most of the literature says if you do 4 or 5 sacroiliac mobility tests, your sensitivity and specificity of testing goes up quite a bit. So you could be more accurate and sure that what you're doing is actually testing what you're measuring. So that's what we're going to look at, doing several tests together, not just 1 or 2. When you're comparing your findings, you're putting the whole clinical picture together, again, because they say that these tests are not necessarily reliable for palpation. What's your patient presentation? Typically, if the SI joint is hurting, there's something going on there. They've done some studies looking at actually injecting the SI joint in people who have sacroiliac pain with a nerve block. Anatomical landmark palpation, another one where several studies say it's unreliable. There's other studies that say it's reliable across all different physical therapy and chiropractic journals, as well as the osteopathic journals. One of the best studies done was at an osteopathic medical college. They took physicians that teach palpation, that teach muscle energy and manipulation, and they put those expert physicians together and compared inter-rater and inter-rater reliability on their palpation. They were completely off. It was very poor correlation. So here they're taking supposed experts in the field, and they can't even agree on which side is anterior, posterior, higher, or lower. So it's a good question about what's happening with our palpation. Pain provocation testing, that's a key. And I put up here, anywhere you see names, this is where some of the resources are, and you have a bibliography for that. Ryman, by the way, has a really good website, which is free with lots of functional outcome measures and the latest in examination and treatment interventions. Michael Ryman, you might want to check that out or write his name down. Free information. Some of the articles I have here on the side about the reliability of these tests are from there. Pain provocation testing. If you match these things up together, you know you have sacroiliac issues going on. 5 items you want to palpate here. Now in your manual, it looks like it listed only 4. Okay, so there's a couple, ASIS, I put that all in the same line in your manual. It's medial and lateral or superior and inferior. Those are actually 2 different items. Where is the ASIS? Is it an in-flare or an out-flare? Is it medial or lateral to the umbilicus? Is it higher or lower, superior or inferior relative to the other? So those are 2 items. And the others, of course, your pubes, pubic rami, pubic tubercle is 1 higher or lower. And then your PSIS is 1 higher or lower. So you're just checking all of these bony landmarks. And lastly, the sit bones, the ischial tuberosity. You can check these landmarks in standing. Some are checked in supine or prone on the table. Okay, special tests. Here's one of the things that comes up from Good. Quote, motion of the SI joint is limited to minute amounts of rotation and translation. And this is one of the reasons they say our palpation is unreliable. Can you really detect that small a difference? Okay, so clinical methods using palpation might be a little bit unreliable or have they say it very politely, limited clinical utility. And here's some of the motion at each axis of the sacrum that they identified. Okay, across the y-axis, minus 1.1 to 2.2 degrees. Okay, I'm sorry, x-axis, minus 0.8 to 4 degrees. So there's quite a difference in degrees here across people. Of course, people have little different anatomies. And 0.5 to 8 degrees along the z-axis. That's a huge difference, 8.5 degrees difference. So everybody's a little different. Go by what you see functionally with a patient and put all these tests together. Okay? Translation, again, millimeters, there's huge differences. Now before we do the actual test, I'd like you to palpate the landmarks. So come in from the back of the patient, put your hands on the waist with the web space of your hand on each side of the waist. Feel that iliac crest. Push in and down, you can feel the iliac crest. Then palpate it with your fingers. Feel it on both sides. Put one finger, like your index finger, whichever finger you want, index finger at the top of the iliac crest, and compare side to side. Are they level? Is one higher than another? Just grossly getting an idea. Have your dominant eye level with the landmark. Close one eye. Check out the iliac crest. Make windshield wipers out of your thumbs. As you do that, you can easily palpate where do you feel the bony prominence of the PSIS. So you might have to bring your thumbs a little medial, a little lateral, depending on how wide they are or how long your fingers are. Make little windshield wipers. I just found it's an easy way. You can look for the dimples. It's another way to find the PSIS. You see those little cute dimples winking at you? PSIS is underneath those. Approaching the PSIS from the bottom, the inferior aspect of that bony prominence. And look with your dominant eye exactly level with that bony prominence. So you might have to kneel, you might have to sit, you have to get down there. I see a lot of people's eyes above that bony prominence and you're not measuring accurately. Another reason why they say we have no idea what we're doing in the literature. Get your eye exactly level. If you have to bend over, you have to bend over. Is one higher or lower than the other? Write it down. Right ASIS elevated, left ASIS inferior. Now come to the midline. You can feel there are spinous processes on the sacrum. See if you could palpate those spinous processes. Go just to the middle of the PSIS. Palpate the spinous processes so you can feel the midline of the sacrum. The superior aspect of the sacrum is called the sacral base. I used to get confused by that because usually you think the base of a triangle is the bottom. The sacral base is the top of the sacrum because it's an inverted triangle. Okay, so find the sacral base. Now, as you're palpating, palpate down the sacral spinous processes. You could feel the bottom of the sacrum. Put your fingers just about, depending on the size of the person, an inch or two lateral. See if you could find the inferior lateral angles, ILAs. The bottom of that sacral triangle, just before it reaches the point of the coccyx, where it's still a little bit on the wide side, that's the ILAs. There are two bony prominences on either side. Basically, they're fused transverse processes. Now notice, is one more prominent than another? Just something to think about. That's what we're going to be palpating ultimately. Now turn around to the front of the person. Do not have the person turn for you. Because once they move, didn't they move their feet? One of the reasons, in my opinion, that this is unreliable is once the patient moves, now they're in a different position. How many people toe out on one side? How many people had their feet closer together before and when they move, now they're farther apart? This changes your bony landmark palpation. So put your web space of your hand between your thumb and index finger on the waist again, push in and down, find the iliac crest. They are the bony prominence right above where the hip bends. So if someone has a little extra meat on their bones, that's okay. If they flex their hip a little bit, just above that crease, you will find the ASIS. Put your fingers underneath the inferior aspect, or what we call the lower pole, of the ASIS. So you're coming at it from underneath, from the inferior aspect. Okay, so put your web space between your thumb and index finger, level with the waist, push in and down. Medial, inferior, feel the top of the iliac crests. Take a single finger, whichever one you want. Always do it the same way. Check the iliac crest levels with your dominant eye. So you got your iliac crest. Decide if one's higher, lower, or otherwise. Next, we're going to find the PSIS. If you're palms are on the top of the iliac crest. Your thumbs become like windshield wipers. Okay, so move your thumbs, ab and adductor thumbs, in other words, and feel the bony prominence of the PSIS. Naturally, you have to get their clothes out of the way. Elastic waistbands are a big problem. Move them out of the way. You want to feel the inferior pole of the PSIS, or come up from the bottom of the PSIS. There is a little dimple there. You might see a little depression, a little shaded depression, a dimple, that's where it is. Don't push on the person so hard that you're pushing them over. That's also a common error. Now, if you go back to the PSIS and palpate just medial to it and slightly superior up toward L5, so just a little medial and superior to the PSIS, that's your sacral sulcus, or the little space. So palpate that. It's just lateral to the spinous process, medial to the PSIS, that space you feel, sacral sulcus. Now, something that can throw you off. Some people have lipomas, little fatty cysts, right? Look, feels like they have these little bulges subcutaneously. Sometimes it feels like these fatty cysts, if you push on them, they slip out from under your finger like a wet bar of soap in the shower. So if you do find they have those little fatty cysts or so-called lipomas, tell them check with their physician. They're usually benign fatty tumors, but sometimes they're not. Rarely are they anything but benign. But I always tell a patient, yeah, you notice you have these little areas here that are a little bit lumpy. Yeah, oh, I've had that. What is that? So it often gets sore if you start pushing and mashing them with your fingers, so don't do that. Tell them, well, have your doc check, when you go for your next checkup, have them check it for you. It's probably a fatty cyst, not uncommon in this area, but put the onus on them. Check with your physician. I've had patients say, I don't go to doctors. Well, you will now. Make an appointment. You should go and have a regular checkup at least once a year. So when you go, you see them. Okay? So those lipomas, just leave them alone. They're not bony prominences. They move subcutaneously. They get kind of slippery under the skin. So you're going to kind of feel around them if they're in the way. Posterior superior iliac spine, PSIS, you're going to palpate them from the inferior pole. Okay, so some people poke at the top, the middle, the bottom. We're going to go from the inferior pole, PSIS. Okay, just medial to PSIS, you're going to find the sacral sulcus. It feels like a depression, sacral sulcus. Also palpate the spinous processes of the fused sacral vertebrae. So S1, S2 are center of gravity, S3, S4, and the tailbone, the coccyx. You should be able to palpate that all the way down. The base of the sacrum is actually the articulation with the intervertebral disc from below L5. The apex of the sacrum is actually at the point here where it connects or articulates with the coccyx. The other palpation would be the ischial tuberosities or the sit bones for palpation. And then iliac crests, palpate both anteriorly and superiorly and posteriorly. Anterior superior iliac spine, or ASIS, you're going to palpate that from the inferior aspect. And then from the front, this will be done in supine, pubic tubercles, or the superior aspect of the pubic rami, both sides. These are the tests to look at sacroiliac joint mobility, or some people will say iliosacral joint mobility, to tell the answer to a question. Is the SI joint locked or stuck on one side? We want to answer the question, which side is hypomobile or stuck? Because if we have several tests that say the SI joint is hypomobile or stuck, then it's a pretty good indication, according to recent research, that 4 or 5 of these tests are all positive. Well, we probably have an SI joint dysfunction, and that's basically what we're looking at. So I'm going to guide you through this by talking you through it, so stand up. Palpate the PSIS. So to find it, put your web space of your between index and thumb, iliac crest, push in and down. Use your windshield wipers, find the PSIS. Put your thumbs under the inferior pole of PSIS. Now, standing flexion test. They're standing, they're going to flex. That's why it's called the standing flexion test. As they flex, you're going to see the PSIS move. They should move symmetrically. When the patient flexes, we tell them, Bend your chin to your chest, then bend your chest forward, then bend forward as if you're going to touch your toes. Slowly, go ahead, bend. Palpate the PSIS. Does one PSIS move more superior or first? The PSIS that moves superiorly or first is the one that is locked or stuck, moving as a unit. So if the right PSIS moved first and moved more, that is the one that is hypomobile. It is locked. You will write it down. Right SI joint locked on the standing flexion test. Okay, stay right where you are for the next test. It'll save time. Same therapist. We're going to do what's called the stork test. Some people call it a march test. It's like you're marching. As the patient lifts one foot off the floor and flexes the hip to 90 degrees, you're going to notice the motion of the PSIS. So ask the patient, lift your right leg up so you see them flex their right hip about 90 degrees or so. The patient might want to hold on to something. Some people don't have good balance. They can hold on. The side with the least motion is hypomobile. Compare. So right side, take a look at how that looks. Now switch, lift the left leg. Look at how that works. Make sure they're flexing 90 degrees each time. If you flex a different amount, you're going to get a different result. So they're flexing 90 degrees each time. Some people make a distinction with this test and they change the name to the Gillette test. So you can change it now, just listen, don't talk. Palpate S2 with one thumb. Palpate the right PSIS with the other thumb. Palpate S2 with one thumb and the left PSIS with the other thumb and ask him to lift the left leg. Compare the motion of the PSIS relative to S2. That's another way to look at a similar test. They call it the stork test, they call it the march test. Wouldn't it be nice if everybody called it the same thing? So you're looking at relative motion. The side that moves least is hypomobile. There should be motion between the PSIS and the spinous process of S2 as they flex. That SI joint should be moving. If it's not moving much, it's stuck. If it's not moving at all, it's really stuck. Some people compare the relative motion of one PSIS to the other, but if you want to call it a different name as what's in the literature, Gillette test, one thumb on the S2 spinous process, one thumb on the PSIS. What is the relative motion right versus left? Pain is not a positive test on these. This is about mobility. So your assessment is to palpate the PSIS movement relative to the sacrum. This is ilium movement on the sacrum. You're looking how much does a PSIS move relative to the sacrum. There's a rotation going on here. Does one rotate less? It's stuck. Okay, is everyone good with those tests in standing? Let's think about this. If you're standing, what muscles in your legs might be affecting movement of the ilia? Hamstrings. So how would you cancel out the hamstrings? I'm just going a little bit out of order for one extra test here for the sake of making a point. How do you cancel out the hamstrings? Hamstrings attached to the ischial tuberosity. The hamstring's tight. Will it let that side of the pelvis move as effectively? No. So how do you cancel out hamstrings? You have them sit down. Preferably in the clinic, you will have your patient's feet supported by whatever, a chair, or you'd have a table that electrically goes low so their feet are on the floor. Feet should be supported. Therapists will stand behind the patient. Okay, now the patient's knees and hips should be at 90 degrees. If your chair is too high and the knees are higher than the table, it's not accurate. So 90-90 position is the proper position when you're in the real clinic. We're in a classroom here today, we're winging it. So 90-90 would be the way you want to work. Palpate the PSIS as the patient flexes head first, chest, and then down at the waist. Flex, flex, flex. Look at the relative movement of bilateral PSIS. Your right thumb's on their right PSIS, your left thumb's on the left PSIS. Repeat the test. Have them come up again. Put your dominant eye exactly level with those landmarks. Get down there. Flex forward. Bend your chin to your chest. Bend forward. Go. Bend, 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 bend. Look at the relative motion. Both PSISs should elevate together. Here's an example. If you cancel out the hamstring and they're still stuck on one side, meaning one side moves first and moves more. Ilium and sacrum are stuck together. That joint is locked. It's a contracture, whatever it is. It's a myofascial restriction. Something's making it lock. It's muscle tension. Then that's the side that's hypomobile. So the side that moves first and more superiorly is the hypomobile side. It doesn't make sense when you think about it. The side that moves more is hypomobile, but that's because we're testing motion of the ilium moving on the sacrum. We fixated here this time by sitting them down. So you canceled out the hamstrings. Okay? So that's a positive seated flexion test. Use the standing and the seated test together to indicate whether that joint is stuck or not. If it's still a problem in sitting, the hamstrings weren't so much the issue. If it's different between sitting and standing, you could think, oh, maybe the tight hamstrings in that side made that side stuck. Okay, something to think about. Okay, we're going to do the next test, which has a relatively high level, like up in the 80s and 90s, in terms of sensitivity and specificity, and it's called the squish test. Other articles call it the compression test. You know, very annoying how you could read 3 different articles and they call the same test by 3 different names. So that's an issue. Lay your partner supine, so have someone on their back on the table. Now here we're going to see if we are squishing the ASIS together, in other words, pushing them posterior and medial with our hands, how much motion is there relatively on the right side versus the left side. So much of this relies on the tactile sensitivity, the proprioceptive sensitivity of the therapist, that you can feel what's going on here. I like to come in from the inferior aspect of the pelvis, and with my hands, instead of poking them with the fingers and tickling them, I come in with a flat hand. Flat hand, where is the bump of the ASIS? With my flat hand, there it is. There's the inferior aspect of that bump. What do we see here? This is a nice place I could look at some levels here when they're laying down. How are those ASIS levels? To do the squish test, I'm going to push medial and posterior on both ASISs. So I'm going to take my palm, heel, and push in and back. And they may have pain. This is compressing the anterior aspect of the SI joint and gapping the posterior aspect. So when we're talking about these particular tests, we're looking at the anterior SI joint. Squish. Any pain with that? No. And you can see how squishy is it on one side compared to the other. Sometimes I'll oscillate a little bit just to get a feel. Go ahead and check it out. The side that doesn't move as much is hypomobile. You might feel it's bouncy on one side and just stops dead in its tracks, solid on the other side. That less bouncy, solid side is the hypomobile side. That would be the positive side for positive test. Whether or not they have pain here is not the issue. Okay? Pain tells you you have to look more carefully at all the groups of tests together. Some people I squish will have pain when I squish them. Another patient will have pain when I let them go, when they rebound from the squish. I'll make a note of it, but that is not diagnostic in and of itself. We're looking strictly at mobility. Pain, it's an interesting addendum. Squish test, compression test. Compress the ASIS posterior and medial. Put your palm heel lateral to the ASIS. Because you want to push them medial and posterior. So you want to push them toward the umbilicus and down toward the table. Okay, let's look at the next test, the tug test. Some people call this the sacroiliac gapping test. Some people call it the tug test because you're tugging on the leg. If we get our act together and come up with a standardized nomenclature, you might have a chance of getting reimbursed for this, you think? Okay, so start, even if it's just starting with your clinic here at Athletico. Make sure everyone's using the same terminology. Pick the name, that's it, that's what we're going to call it. Everyone uses the same nomenclature. Okay, so the tug test or gapping test, if you abduct the thigh about 20 degrees to 30 degrees, you're just relaxing and opening up the SI joint. So on most of these SI tests and corrections, we're going to be abducting a little bit. So abduct the leg, you're testing a little bit about 20 degrees. I'll say like I'm doing the right leg over here. As long as their knee is okay, you can tug from the ankle. if the knee, maybe she had an anterior cruciate ligament repair and you don't want to be yanking on the bottom of the leg and affecting that repair, I could tug on the femur. Ultimately, you're looking to palpate the SI joint here with your fingers, so find your PSIS. Come just inferior to that, you could feel the movement of the joint. Grab that leg, I'll just hug the whole leg between my arm and my body and just lean back to tug a little. How much motion do I feel there at the SI joint? Some people like to do the tug test and feel, I'm just going to push on the buttock here, ischial tube. That's a nice way to look at, do they have an upslip or downslip? So tug or distract through the leg, or do long axis distraction. How much motion do they have at the ischial tube? So 2 ways to look at it, SI joint or ischial tuberosity. Now it's important not to extend the leg too much when you're doing it because sometimes this will hurt the SI joint on some people. So keep the leg more flat against the table if you can. Try not to extend the hip too much. Now from the same position and the same handhold, if you're doing that tug test where you're distracting the leg, you're now going to do the opposite and compress the leg straight up into the acetabulum. So it's easy to do these two tests together. Cradle that leg, put a superiorly directed force right up into that acetabulum and press at the SI joint. How much motion is there as you compress? So it's longitudinal compression. Take care not to hyperextend the hip. A lot of you are lifting up people's legs. Keep the leg on the table so you don't have to lift it, saving your back, and compress straight up, that femur straight up superiorly. Good, nice palpation. Right into the acetabulum. How much motion is there at the SI joint? There should be some superior glide. If you find one side is simply stuck, you try to push up and you reach a block immediately. Okay, that's probably a down slip. So if you have a limited superior glide as you're gliding that femur up, it's probably a down slip of the ilium. Conversely, if you did your distraction tug test and you found that was limited, it might be an upslip. So these are your indicators, upslip or downslip, tug test or compression test. So remember we did that Thomas test position earlier. We hung the person's leg over the table with the other leg up. Well, there's a similar test to that called the Ganslin's test. And here's another situation where in the literature I've seen it and I've documented it done 2 different ways and listed as the unaffected side reversed for each one. So I think this is one of the issues that comes up, at least what I've noticed with muscle energy courses, is you read the literature and one person's talking about a position they're stuck in, another person's talking about the limitation of motion. One person's saying the affected side is the bent knee and the other person's saying the affected side is the straight knee. And these tests are crazy. So I've seen this here with the Ganslin test. In your notebook, okay, you'll notice, and just look here, this Dreyfus is the recommendation. It's not a typo. This is what they have. But other tests here, the involved side leg is extended. Dreyfus said the involved side leg is flexed on the test. So just make a note in your book, get your book. I've seen it written both ways in the literature. So classic Thomas test position, but in Ganslin's test they typically don't put the person on the bottom edge of the table, they put them in the middle and scoot a little my way. Good, that's good, that's fine. They keep one leg flexed fully at the hip, the other leg I'm going to hyperextend off the table. Now, typically for my patients who have sacroiliac joint problems, I start hyperextending that leg, that SI joint just lights up with pain. So in the Ganslin's test, I'll consider the hyperextended side to be the positive side. Some references, like I said, will consider that I'm testing the opposite side. And I'll be honest with you, I have had some patients say the SI joint hurt on the right side when I extended the left. Either way, you're torsioning across the sacrum. So it might be either side. Just be aware it's in the resources listed both ways. But what I find personal experience, that hyperextended side usually really starts to hurt. So you do that overpressure. We would say, oh, left SI joint hurt with overpressure of left hip extension. Left SI joint is positive for involvement. So go ahead and try that with your partner. Thank you. Sensitivity and specificity for this are 0.71 and 0.26. So sensitivity is good, specificity is not. Find another study, they say something different. Every study says something different. So this is often called the thrust test, the femur thrust test, the thigh thrust test. Some people call it the sacroiliac thrust test. If we could just get it together and come up with a name, that would be lovely. So say, move a little bit to my side of the table. Good. And you can put this leg down. Now, should her leg be hanging off the table sloppy like that? No, get up on the table. Good. That's okay if you're tall. I'm okay with the fact that you're tall. All right. So hip at 90 degrees of flexion. Now, you have to be careful with this if someone has knee problems because you're pushing directly posteriorly through the femur. Okay? So if they have a patellofemoral problem, do you think they want me squishing them here? Probably not. Okay. For some people, and again, this table is quite low for me, if that's an issue, I might need to circle the femur and push in from there. So if they don't have so much of a patellofemoral problem, push directly posterior right into that SI joint. Now first I'll just get a feeling of the motion. Next I want to see, can I palpate the SI joint and feel how much motion does she have? And I'm leaning my body weight right into my arm because this takes a little force to do. Now I've seen the test listed as push and just compare the motion or look for pain. I've also seen it as push and hold it for 30 seconds. That's hard to do because this requires some force. So if you have your body weight behind you, this is one time when a lower table might be more effective, I can get my body weight behind me. Some people will push and then thrust or bounce a little at the end. And it has a high level of sensitivity and specificity for SI joint problems. So go ahead and try the thrust test. You're compressing right into that SI joint.
They have like a label.
With any of these hip tests, if they have problems in the labrum and you start flexing them, adducting them, rotating them, that's going to be in the way, so you won't be able to do the test. You have a confounding factor, so have them check to see, do they have a labral tear? There's, another 6 tests you could do to check for labral tears.
I feel like that would hurt some of the posterior.
Yes, it would definitely irritate someone with a labral tear. Also an anterior impingement of the hip joint. If you're flexing them up, some people at 90 degrees, and you start thrusting that femur, that impingement might come up as well. So you need to rule out the hip with all the hip tests as well as these. Yes, thank you. These are great comments. Excellent.
You're welcome.
So let's go into the next one. Sacral thrust. Patient is prone. You're going to apply a PA pressure right through the sacrum. So have them prone. Palpate where the SI joints, PSIS. Palpate the sacral tubercles. You want to be right over that S3 with your palm heel. Move a little closer to me, please. I want to put a direct posterior to anterior thrust through the sacrum. And is it painful? Is it stuck? Get a sense. Go ahead and check it out. Short amplitude PA glide of the sacrum. This is a mobilization test. You oscillate. Posterior to anterior thrust. If the motion is limited or painful, it's positive. Center over S3. This is a general sacral thrust. You are in the midline of the sacrum over S3. Let's look here. S1, S2, midline of the sacrum, direct thrust. Okay, next one. This is a little different test, and I haven't seen much on it except in one study on specificity, and they did feel it was very specific. It has more to do with instability. And it's interesting because when I have patients like going to physicians to look at maybe their workers' comp case, they're checking out what % of disability they have, everybody's worried about limited range of motion from the disability perspective. But then you get all these patients who are hypermobile in other areas or unstable. They don't seem to consider that a disability. Anyone notice that when you get in your patients who have like accidents, lawsuits, especially workers' comp? Instability doesn't seem to be an issue unless like the joint is completely out of place. Yet for us, even a slight instability of a joint, typically one side of the sacrum, SI joint is hypermobile, the other side is locked. So you free up the locked one. What did you do for the hypermobile side? What should you do? How about stabilize? Exercises, bracing if necessary. It's just something to think about. We're looking very much, because this is how we're trained, what's hypomobile? That's something I could do something about. If the sacroiliac ligaments are overstretched and they're hypermobile, can you do something about it? Can you put ligaments back that were overstretched from an injury? No, not unless they do something surgical. Take 3 titanium screws and fuse the SI joint, and that's what's being done. But in the meantime, what can you give a patient? An orthosis or a brace. Typically right just below the iliac crest, right around the whole pelvis. They have those all kinds of different sacroiliac belts available. So something to look at what's out there in the market. We're focusing on what's hypomobile because that's what we're mobilizing here, but follow through with your stability exercise programs, learn about your Pilates programs, your spinal stabilization, because we'll touch a little bit on those exercises today, but mostly we're looking at muscle energy. Just be aware there's more to the picture. So for the instability test, have your partner or patient in supine, so get your partner on the table supine. Now on this one, again, I like patients always close to me so I could test and feel what's going on. We're checking if they have some instability, too much motion in the SI joint, they're going to have a problem with weight bearing on one side, weight shifting, and doing something like a leg raise. So I'll ask them to actively do a straight leg raise separately on each leg, with and without my stabilizing their pelvis to see, do they have difficulty? Possible hypermobility, laxity of the SI. So as you're laying here, make your feet like straight, okay? Lift up this leg. I usually have them lift about halfway. Any problem with that? Okay. What if they happen to be really weak in their hips? Can this test help? It might be another problem, right? Say he was laid up in the hospital for a few months and just got deconditioned. This might not be as accurate a test. So somebody who has like relatively, 3+ or better on the strength. Now lift this leg up halfway and relax. Now if the patient had pain in the sacroiliac joint when doing an active straight leg raise, that's telling you there might be some problem with controlling that joint. There might be some instability there. So if he said, let's pretend, oh, when I lifted this leg, I felt that pain in my back, and what he meant there is the SI joint. Okay, so he felt the pain there on the left straight leg raise. I wonder what would happen if I gave him some stability by pushing those ilia together, or getting a sacroiliac belt or a big Velcro strap and strapping the pelvis to keep the pelvis in a very stable position. So I'll squish together, lift your leg, let it go. Oh, that pain went away that I had before. That felt better when you pressed on my hips. So I'm pressing on the ilia medially, bilaterally, simultaneously. So that gives them some stability. I could then get a sacral belt and have a couple extras of different types in the office, put the sacral belt on. Here, now you do it by yourself with the brace on. Oh, it's fine, I could do it then. That's showing an instability problem. So go ahead and try that with your partner, please. Thank you. Okay, next test, the Patrick, or some people call it Fabir, flexion, abduction, external rotation test. And so come in, you're doing it, go for it. He knows what he's doing already. So take the hip, flex, abduct, externally rotate together like a figure 4. Hold one ASIS down on the opposite side while you put a little overpressure. If the SI joint hurts on the side that you flexed, abducted, and externally rotated and compressed, positive. So it's a pain provocation. If it hurts in the hip, that's a hip provocation test. So maybe they have problems with the hip joint capsules tight or something, it'll hurt in the hip. But if it hurts in the SI joint, you're really grinding that out with this test. Okay, modified Trendelenburg. This is looking at SI joint for pain and also poor neuromuscular control or poor control, generally weakness like gluteus medius, some of those hip abductor muscles. So have your patient in standing. It's easier if they hold on to something just lightly. Tell them, oh, can you bend your knee up in the air level with your hip, or 90 degrees hip flexion as we would have it. If they're having problems With balance, have them hold on to something. Gee, I wonder if it's really a balance issue. Is it when they lift their leg, does that ilium drop on that side? Maybe some weakness in the gluteus medius and the opposite side. So if they lift up the right leg and you see, oh, that right hip drops, what's weak? Left gluteus medius. So they might complain of SI joint pain. So if there's issues there, that's another possible positive indicator of SI joint. Okay? So stance side leg is the side you're testing for the pain. If I'm standing on the left leg and left SI joint hurts, it's a positive test for the left SI joint. If I'm standing weight bearing on the right leg and the right SI joint hurts, it's positive for right SI joint pain. For the modified Trendelenburg test, they have to stand there for 30 seconds. They have to maintain that standing 30 seconds. Pain in the stance leg on the SI joint is positive. So this would be a left positive test. Oh, my left SI joint hurts. Some people call it the flamingo test because you're standing like a flamingo. Another problem with the literature, 20 names for the same test. Now, the normal time that a healthy adult should be able to stand on one leg by itself is 10 seconds or more. So for most of our patients, asking them to stand on one leg for 30 seconds is quite a lot. So let them touch, I tell them fingertip touch the table for balance, or they could touch the wall next to them for balance. Okay? Because it's going to be really hard for a lot of them to stand that way anyhow. 10 seconds is considered normal time that a healthy adult can stand on one leg. If you're doing a standing flexion test and then you're doing a march test, wouldn't it be easy to go ahead and check your SI joint mobility with the march test and then ask the person, just stand there now for 30 seconds? Wouldn't that save you some time? So think about the tests you might want to combine when you're doing this work. Okay, last test is going to be, it's a little different. A physical therapist named Jerry Hesch does a lot of really good sacroiliac work and has combined a lot of things, I think more reliably than some of the work I've seen before, and I'm starting to see this in literature too. Instead of just doing straight tests, why not check the actual mobility of the sacrum in different quadrants? If you take a sacrum and you imagine, you have top, bottom, left and right, and you're dividing it into 4 quadrants. Imagine you just took that upside down triangle of sacrum, divided it in 4. You have the right upper quadrant, the right lower quadrant, the left upper quadrant, the left lower quadrant. You see there could be like 4 quadrants. I can push selectively on each of the 4 quadrants with a PA glide or a posterior to anterior oscillation mobilization and see how springy is it here? How springy is it on the left? How springy if I'm on the right ILA versus on the left ILA, inferior lateral angle. So we're going to spring the right and left sacral sulcus. We're going to spring the right and left ILA, inferior lateral angle. All 4 quadrants. How springy are each of those? If someone has sacral flexion or extension rotation dysfunctions, or if they have a torsion dysfunction, you're going to see that there's not as much spring in a very precise area. And in some cases, I've done muscle energy on sacrums for torsion, left on left, left on right, forward torsion, backward torsion, these things, and nothing seemed to correct. But then I went in and started mobilizing the old-fashioned way with my spring test coming positive for limitation of motion, and I found, oh, that really freed it up. Then the muscle energy starts to work. So if you're frustrated and you tried some of the muscle energy corrections that we're going to learn and you're finding, well, that just didn't correct it, you have to think about what is holding it stuck. Soft tissue contracture, capsular thickening and fibrosis, muscle tension, piriformis, glutes, psoas. So you have to deal with that soft tissue as well. Don't just think that doing a little reflex quickie muscle energy contraction may be enough. Personal opinion, I find it is quite enough for someone in the more acute stage where it hasn't fixated there yet. But in someone who's been that way for months or years, which is very typical of the kind of patients I see in my clinic these days. I'm getting the chronic people that had, 3 different accidents, fell down the stairs, happened to have fibromyalgia too, and then now they had another car accident and they're stressed out during their divorce. So how many things are wrong with them right now? Oh, about 25. and they've seen 5 other therapists, 3 other chiropractors, and 2 physicians, nothing changed yet. So it's a little more involved. I like to go ahead and try my 4-pole spring tests in the 4 quadrants. So go ahead and put your patient in prone, and I like to use the palm heel of my hand. Some people will use thumb over thumb. So depending on how you want to spring, you could use your right where your pisiform bone is in your palm heel and the ulnar side. You could spring left or right ILA. Sometimes I'll go thumb over thumb. Depends on how big is this person's sacrum. Am I working on a 12-year-old or am I working on somebody who's a football linebacker? It'll be different. So go ahead and try the springing all 4 quadrants of the SI and just get a sense what's bouncy, what's stuck. So looking at anatomical palpation tests, as we said, a little questionable, but there's certain tests that if you put together, it shows you a preponderance of likelihood for iliosacral somatic dysfunctions. And that would be these, the positive flexion test. Standing flexion, how does a PSIS move? Sitting flexion, how does a PSIS move? The side that moves up and superior first is the lock side, remember? You write that down. The squish test. You're pushing those ASISs from their most lateral aspect. You're pushing them with your palm heel medial and posterior at a 45-degree angle. You're noticing that they are hypomobile on one side. Might even be painful to the patient, but it's the mobility we're looking at. So if those tests are positive, then you put that together, okay? Very likely to have a problem in the iliosacral movements, movement of the ilium on the sacrum. So let's correct them. Elevated or depressed pubis. It's recommended, I've seen this in the literature, but I haven't really seen it work clinically that it matters what I do first or second. In my clinical reasoning process, I ask myself, what is most limiting to the patient? What is most impairing to the patient? That is what I'm going to treat first. What is the most obvious hypomobility or the most painful area? That is what I'm going to treat first. What's most in the way of their everyday activity, living movements? That is where I'm going first. Not necessarily the book said first treat the elevated or depressed pubis, then treat the upslip or downslip in the ilium, and then lastly come around and fix the in-flare or the out-flare. When you're done playing with that, then you can look at the pelvic rotations. But that order in which I show you here is typically the order in which it's listed in the literature to treat. I haven't seen a difference if I treated one first or the other any better, although other people out in the field will tell you there is a difference. What's most impairing to the patient? I treat the worst first is typically where I go. So use your own clinical reasoning, see what works in your patient, because the jury's out on really where to go first, in my opinion. But we'll go here. So pubic bone dysfunction. If the pubic bone is elevated, we're going to palpate now the pubic tubercles. We're going to come in with a flat hand, inferior to the umbilicus, press very softly on the lower abdomen until you feel that prominence of the top of the pubes coming in directly, and from that point then you could take your fingertips or thumb tips and palpate the pubic tubercles. Is one higher or lower than the other relatively? The higher side we'll call an elevated pube, the lower side we'll call depressed pube. Which one really is it? It's named by the side of the hypomobile SI joint. So if the right standing flexion test, the right sitting flexion test, the right squish test was all hypomobile, it's a right elevated pube. Right? Got it? Okay. So let's go ahead and palpate. Put your partner in supine on the table. So palpate. Where's the top of the pubic bone? Bilaterally. Remember, there's a symphysis, cartilage in the middle. There is some shearing in that pubic symphysis. If I come in from the sides with my thumbs, it's often more comfortable for patients than I come right in the middle. Palpate for those pubic tubercles. Now, just a little privacy issue. Men have an extra protuberance in their perineum. If it is in, depending, right? If it is in the way, you can ask the person, tell them what you're going to do. I'm going to palpate the top of your pubic bone here to see if you are level or not. It has to do with your back pain. Could you just adjust yourself so there's nothing in the way? Thank you very much. And I turn around and they adjust themselves if need be, and then I can come back in and palpate. So just a little personal issue that sometimes comes up with some people. Use your dominant eye in the center. Please write down for your partner which side was up and which was down, or were they level. Take care to note that the pubic tubercle is often very sensitive with a trigger point. Don't go poking at them and hurting them. Okay, iliac dysfunction, iliac upslips or downslips. For all of these, we're naming them by the side of the hypomobile SI joint based on your flexion test, your squish test, and all of your other tests. So for iliac dysfunction, an upslip or downslip, these are called pathological dysfunctions, meaning the ilium doesn't naturally glide up the pelvis or down the pelvis separately as a separate entity. So if it's gliding up or down, something is seriously wrong. Okay? So it's considered a pathological or an actual subluxation. The other motions, the pubic motions, the pelvic rotations or torsions, they're natural movements that are physiological. It occurs during everyday walking and moving. It just might be exaggerated in a dysfunction. But for an iliac dysfunction, upslips and downslips are always pathological. It is not a normal motion the body does for a living. So it's something you really want to correct. And although other people correct other things first, sometimes I like to correct this first because it's pathological. So to me, it's more of an impairment. It's not a natural thing that occurs in everyday living. So an upslip, palpate the ischial tuberosity. You can do that in prone. Which ischial tube is higher? That's considered the upslip. The one that's lower, considered the downslip. How do you name it? The SI joint that's locked. If the right SI joint is locked, it's a right upslip. If the left SI joint is what's locked, it's a left downslip, right? Same thing, we're just naming it that way. So put your partner in prone, let them know you're going to be right at that gluteal crease, and you're going to palpate the ischial tuberosities. Let's get a model. So here, coming in, find the gluteal crease, you're palpating ischial tuberosities. Use your thumbs, it's the easiest. Which side is higher? Have the patient's body close to you on the edge of the table. Sometimes just my personal thing I like to do, I haven't seen it in the literature as anything, sometimes I'll do a little superior glide of the right ischial tube or the left ischial tube, just do a little oscillation. Do I feel like one side is more stuck than another? The side that does not glide up might be downslipped. Okay, something to think about. It's more common that I find someone upslipped because patients are typically falling on their ischial tuberosity, causing that side to slip up. Sometimes I'll find a downslip in somebody, a patient who fell off a horse. Her foot got stuck in the stirrup and she was dragged. That created a downslip. I had another patient, one of my long-term fabulous patients, came in, and after we finally fixed his back and his neck and all the other things he hurt, oh, I was cleaning my boat and I fell off the boat, and he had this big 38-foot yacht, and he had a piece of the boat grab his wedding ring. And he's hanging from his wedding ring, and then he's hanging from his other foot where his shoe grabbed a hook. There was the downslip. So there he dislocated his shoulder, got a downslip on the leg where the shoe got hooked. So you have to watch it. I tell people, don't wear the jewelry when you're working on these things. So you'll see a downslip in a case like that where there's something that's more of a trauma. Very rarely see it otherwise. Okay? So if you're checking for upslips and downslips, you're palpating the ischial tuberosities, which would be here. In this case, the right side is higher, so that would be an upslip. You know, let's just pretend that's straight. To make it easy to palpate, because this is a personal area for the patient, look for the gluteal crease here, and that's the easiest place to find ischial tube. Get your thumbs in. A little bit of oscillation, straight superior. How is it on one side versus the other side? Here, her left side seems a little higher. Did you find that as well? So a little bit higher on the left. Of course, you have to compare it. Is it a rotation? Is it an upslip? You have to compare all the tests together. Good. Okay, in flares and out flares. Your patient is supine on the table. Put the patient supine on the table. So in flares and out flares, you're palpating the ASIS on the right and left and comparing it to the midline. Now, for most people, the umbilicus is in the midline, but depending on their history of abdominal surgeries, it might not be. So I like to just actually take a piece of tape in a patient, or conveniently She has a jacket with a nice zipper in the middle. I'll try to see, can I put that in the middle of, the sternum here, so I have a straight line coming down. Palpate the ASISs. Which one is closer? Go just to that inferior lip of the ASIS and compare that to the midline. Which is closer to the midline, or are they both equidistant from the midline? In some patients, if it's not easy to see, I'll actually run a little piece of tape, just skin tape down their body and compare and actually measure with a tape measure the distance from the ASIS to the midline of the tape. So the greater distance from the midline would be out flare. The shorter distance from the midline would be an in flare. What do you call it? The side of the hypomobility names it. So if it's wider on the right and the right SI joint is locked, it's a right out flare. If it's narrower on the left and the left SI joint is locked, it's a left in flare, you see? So name it by the stuck SI side. So in flares, the ASIS is medial. In out flares, the ASIS is more lateral. I had patients who were in car accidents with impact that had serious in flares from the impact. I had patients who fell off horses. Same thing, in flare on one side, out flare on the other. Trauma. People tackling each other in a football game. Okay, next we're looking at leg length discrepancy. If someone has a leg length discrepancy, the best way to actually view that is a posture study x-ray. If they actually measure the lengths of the bones on x-ray of the femur and the tibia and so on, now you can see if there's a leg length difference, that's considered a true leg length difference. How else you do true leg length differences? Some people will use a tape measure and they'll measure bony landmark to bony landmark. So they'll come here from, okay, I have the greater trochanter and I'm coming down to the lateral tibial plateau and I'm going to measure that length compared to the opposite side. And then they'll come here and they'll measure from the lateral tibial plateau to the distal tip of the lateral malleolus and they'll look at the length there. Or from the medial joint line to the distal tip of the medial malleolus and look at the actual bone lengths. Now if you're looking at bone lengths through the tape measure, that's one thing if you're good at your palpation, but what about the foot? What if this patient pronates on one foot and doesn't pronate on the other when they're standing? Will you get a correct leg length measurement doing that type of just bone measurement? Not necessarily, because you're missing the part of the foot. What many people do, this is listed as apparent versus true leg length discrepancy. Stanley Hoppenfeld, you probably all have the book Physical Examination of the Spine and Extremities, and you probably saw them. He has a tape measure, and you're measuring from the umbilicus to the distal tip of the medial malleolus. You're comparing that to the opposite side, and they consider that the true leg length measurement. Apparent leg length measurement, ASIS, to the medial malleolus with a tape measure, and compare that on each side. So let's pretend for the sake of the demonstration that the patient had a posture study x-ray and the bone lengths are measured on x-ray, which is completely reliable, and we know that they're equal anatomically. So it's not an anatomical difference there. But when you're looking at the patient, they're standing crooked. And you're thinking, gee, I wonder if one leg's longer than the other, making them stand that way. Now, if they're standing in their shoes and you didn't check them carefully, will you be getting a true leg length measurement? They're standing in their shoes and you're seeing them crooked. Did they tell you that they had an orthotic in their left shoe and nothing in their right shoe? Wouldn't that change your leg lengths? Or how about the patient who said, well, 2 years ago I had heel pain on the right, so the orthopedist gave me a heel cup and I'm still wearing it because it feels good. What's that going to do to leg length? They're only using it on one side. So if you're doing these tests in standing, the patient should be in bare feet. And you can see if they're pronated or supinated one side relative to the other, because that's going to change the apparent leg lengths. So again, for the sake of the demo, the patient's true leg lengths are equal, but I happen to see that he stands crooked. And we'll use the example of what we see more often, probably 80–85% of the time. If they're anteriorly rotated on the right, And just if you're not familiar with this, feeling yourself palpate your ASISs. If you let your right knee bend and your right hip flex a little, you'll feel that right ASIS drop down. And the right PSIS is elevated relative to it. So if you're going from the side, right ASIS is lower than the right PSIS. Anterior pelvic tilt, anterior rotation. What happens to the rest of the leg if they're in an anterior rotation? Well, if they're anteriorly rotated, if the ASIS moves inferiorly, what's right below that? Well, the hip joint, acetabulum. If that moves inferiorly, what's below that? The femur. So that'll go down too, which is attached to the tibia bone, and that'll go down. So it'll look like the whole leg's longer with an anterior rotation. Does this make sense? Relatively with the posterior rotation, that acetabulum is pulled up and back. It'll make that leg appear as if it's shorter. So let's look and see, palpating the leg lengths, and of course in the clinic I'd use a tape measure, but here just to do a quickie, supine long sitting test. So check your ASIS, your PSIS levels in standing. You could do it in supine and prone. If they're asymmetrical, one side's higher than another, you might want to do a supine long sitting test. Look at the person when they're supine, put your arms down flat. Now if he's got one arm up, one arm down, his head's turned one way, might that torque the rest of the body? So you want the rest of the body straight. What if he just habitually lays on the table bent to one side because he's tight there? Some people like to bridge. Bend your knees, put your feet on the table, lift up your bottom, let it go. Some people will try to straighten out the patient by having them bridge first. Let your legs go down. Now, most of my patients who have problems with sacroiliac or iliosacral dysfunctions, they have a lot of pain with the bridge. Some of them can't even bridge because it's too annoying. So I don't ask them to do that. I see it done all the time. I'll just grab their ankles. I'm going to give you some tug. And you're going to feel me slide you. Go ahead and slide. Slide them. Make sure they're straight from there. And here I got them. Put the medial malleoli together. And the body straight. My dominant eye right above the distal tip of the medial malleoli. And what do we have? The right one's a little shorter, guesstimating a ½ inch with the eyeball. Of course, the tape measure should come out and measure to see what the leg length is. So if that right leg is shorter and left leg is longer, what are the possibilities here? A long left leg and a short right leg. How do we fix that? Hack off a ½ inch of the left leg, right? Yeah, send him home with that. No, what could we do? Put a lift under the short right leg. Okay, that may correct it. What if he's the type who wants to wear high-heeled shoes, platforms, and open sling-back shoes? Can he wear a heel lift successfully? Going in and out. What if he wants to wear flip-flops? You ever see some of the shoes people are wearing lately? The footwear is outrageous. If they're not going to wear the shoe lift for a true leg length difference all the time, there's no point in giving it to them. They're going to go in dysfunction, out of dysfunction, in dysfunction, out of dysfunction. So I tell them if they have a true leg length difference, I'll have them get a posture study x-ray or measure the bone lengths and tell them if you're going to wear this shoe lift to try to correct your dysfunction, you're wearing it all the time. Oh, but I like to walk barefoot around the house. Too bad. You're putting it in your slippers, you're putting it in your sneakers, you're putting it in your shoes. Particularly in women's footwear more than men's, the heel counter, the back of the shoe, is often abnormally low. And as soon as you give them a heel lift, the foot comes flying out of the shoe. So that's a problem. Some people will go to the orthotist and they'll put an external heel lift on the shoe to pick them up some. Now if you put just a heel lift, what's happening to the rest of the foot? It's plantar flexing. So I'd recommend they put a lift across the whole bottom of the shoe, not just the heel. You see what we're getting at? The way people correct? If it's not going to work all the time, I tell them, look, you have legs that are unequal, it's making your spine unequal. Unless you're going to wear the shoe lift all the time, you might as well skip it. If you're going to skip wearing the shoe lift, you better keep yourself as strong and flexible and balanced as possible, or you're going to have that back pain again. And this is typically what we're telling our patients. Does it make sense? Okay, so I'm doing my supine long sitting test. In this instance, his left leg appears longer in supine. Now, he's free to move because he's weight bearing on his back and his sacrum. Ilia are free to rotate any direction they like. But once he sits up, come sit up. See, he has abs. Unlike most of my patients, I have to reach and let them hold my hand to pull them up because they can't sit themselves up. core stabilization issues. Sit even on both butt cheeks. You can rest your hands on your sides if you want. Good. What if he had a knee flexion contracture on one side? Is this going to be an accurate test? Or hip flexion contracture? So all these things could mess up your test. Just be aware of that. Now I'm going to do a little bit of pull. Oh, look, it's even. So what might be going on? He's long on the left in supine and equal in sitting. Sitting is more likely the true leg length because he's fixated on his ischial tuberosities. He can't rotate his pelvis. So the side of the long leg is typically rotated anteriorly. So that's something to look at. Other things could be going on, but that's the basics. So let's go flat for a minute and just see. I wonder if his ASIS levels were anterior on one side or the other, or lower on one side than the other. So palpate, and if you notice, I'm not looking at him because I go by feel first. Everything by feel. Then I'm going to take my dominant eye. Oh, look at that. The left side's lower than the right. Can you feel that on your body? This is farther away from your face than this?
Yeah, a little bit.
And this is what I asked the patient. Can you feel it too? You want to know. Can they feel it too? How about on the legs? When he's laying down, can he see that there's a difference? Joe, without picking up your whole body, just pick up your head. Can you see my thumbs? Can you see my thumbnails? Which one's farther away?
Your right one.
Yeah, so your left leg's longer. And I show the patient, relax. Since they say our palpation's so unreliable, let the patient see what's going on and make a difference. And then when he sits up, come sit up again. Even on both butt cheeks, you can lean on your hands some. Don't let those knees flex. How about the thumbs now?
Pretty even.
More even. So I always show the patient, that's the other lesson here, because he wants to see if there's a difference or not with what I'm doing. And it's a lot easier. And sometimes they can even feel that one is very different than the other. Thank you very much. So we'd say a positive supine long sitting test. Left leg is longer in lying. They're equal in sitting, or what we call long sitting. Positive for anterior rotation on the left, or what? Posterior rotation on the right. Which one do we call it in our notes?
Hypomobile.
The hypomobile side. Was one or his other SI joints hypomobile?
Yeah.
The right
Which
one.
one? The right. So he's a right posterior innominate, or a right posterior rotation. Everybody follow? Okay, so go ahead and try that test, please, on your partner. Thank you.
Yeah.
So let's look at some techniques to correct these iliosacral dysfunctions, these upslips, these downslips, these pubic elevated or descended, or in flares and out flares. Okay, we're just using an example again. So have your partner on the table and let's work through it. Let us imagine your patient has an elevated left pubic bone. Put your partner on the table. Let's palpate. So picture of what you're doing is on the board. Correcting an elevated left pubic bone. Why is it elevated? Who knows? Some muscles are tight, typically the adductors and the flexors, okay? So put your legs down flat. Come in, palpate. I got the ASIS. Let's see where pubic bone is. Come in, low, low. Where's we got here? There's one side. There's the other side. Oh, the left side, again, we're just pretending for the sake of the class. The left side is higher. And guess what? He had a positive left sacroiliac flexion test, a positive left squish test. Everything was bothering him, so the left SI is hypomobile. So it is an elevated left pube. What do? We want to bring it, drop it down. How do we do that? I'm going to hang this leg off the table. If you're uncomfortable for any reason other than the stretch in the front of the thigh, let me know. Okay. Many times when you hyperextend the thigh off the table, SI joint starts complaining or the back's hyperextending or something to that effect. If that's a problem, I'll put a pillow under his opposite leg to put his back more neutral. So we're going to extend, palpate the tubercle. You feel a little bump here. We're going to extend the leg off the side of the table. Now I use generally just the extension. Some people add ab and adduction, internal, external rotation. Extend until you feel that stop moving. Very light and gentle. Resist hip flexion. So very lightly pull your leg up toward the ceiling. Hold it, hold it, hold it. Too much, too much. His whole pelvis is moving. He's pulling too hard, and relax. And then drop it back. New barrier. Repeat again. Hold it. 1, 2, 3, 4, 5. Relax. Let it drop down. Get my new barrier. And just relax that leg. You okay with that? I had to tell him to relax his leg because I could feel his muscles twitching and trying to figure out what I'm doing. So just breathe, relax. Good. Pull up. That's it. Pull up a little bit again. Lightly. Light, light, light. Pound of pressure. I tell patients, give me a pound. If they're pulling hard, I tell them, give me an ounce. And they typically give me 2 pounds, and relax. Let it hang. And gravity helps you here. So I'm palpating the pube and seeing it was elevated. This is pulling it down. So contracting, relaxing, hip flexors. Bring back up. Make your arms level. You cross them both across the chest. Check and see, are my pubes level or not? Okay, or actually his, not mine. Yes. Some people use a fingertip. I like to use a thumb. I have one thumb on the pube and the rest is feeling the pelvis move. Some people, the whole pelvis starts rotating. Other things are going on. So I might want to notice that with my hand. But it's really more just I could just have my hand palpating here if I want. I always like to have all my hands, both hands in contact with the body as much as possible because I get more information. But the palpation could be just the thumb tip or just the fingertip, the way it's typically taught. I like everything in contact. I know I could keep him from falling off the table. I could palpate, gee, how much motion is he having there? And it's just better contact, usually more comfortable for the patient. Okay, so let's go ahead and try that correction. Try that with your partner. I typically do a single plane. It's easier on the patient. Some references or some therapists will use triplanar motion. You could do the single plane because it's mostly affected by flexion extension. It's mostly affected by sagittal plane movements. So I choose that one. In a patient that's not too involved, I could do the triplanar resistance, but it's a whole lot easier to do it this way. So on this, and it says on the other slide as well, you could resist flexion or adduction. Some people resist internal rotation. I found that to annoy most people's hip joints. Okay, for the depressed left pubic bone, again, we just arbitrarily picked left. We're making believe the left sacroiliac joint is hypomobile or locked. What do we want to do? We're going to put them in flexion, adduction, and internal rotation. Here's another reason why I tend to treat these in more of a single plane of motion as opposed to triplanes of motion. How many of your patients are comfortable when they have pelvic problems, SI joint problems, hip joint problems? How many of them enjoy being stuck, flexed, adducted, and internally rotated? They're impinging. They have labral issues on some of them. So that's why I'm sticking more with the flexion extension component of these. I'm trying to work with what's more tolerable or comfortable for a patient and still moves the bone. You see, you can use the triplanar motions, of course, if the patient has no problem with it. But for those who have a problem, I stick to a more straight plane, like sagittal plane motion, like resisting flexion or extension instead of adduction, rotation, and everything else. So let's pretend she has a depressed, are we okay there? Snoozing? Getting a good snooze? Get a depressed left pubic bone. So let's come down, same thing, let's palpate. Again, when you're approaching the patient, I might just be a little wary of the perineal region. Let's find the ASISs first. Let's see where is the top of the pubic bone. It's going to be below those ASISs, so those are easy to find with a flat hand. Can I come in from above, push down, soft abdomen, where's the pubes? There we go. There's the top of the pube, so most people really appreciate you coming in from the top as opposed to poking around right in the middle. It's very invasive to patients. So come in from the top, what's happening on one side, what's happening on the other. You okay with that? And people are also very sensitive. There's a lot of trigger points around there when there's pelvic dysfunction. So I don't want to go poking on there right away. So let's pretend we have an elevated or a high left pubic bone, depressed or a high or low left pubic bone. What do we want to do? For the depressed pube, we're going to put them up into flexion. Now here, I have to get my hand out of the way or I'm going to squish it once I start flexing. And I'll resist her underneath her thigh. Don't hyperflex her knee. You'll tend to put pressure on the patella. So I'll resist her from here. Now, flex. As I start to do some internal rotation, you'll see if I have my hand under her thigh and I lean into her, I could get some internal rotation and adduction. Any problem with that? No, she doesn't have a problem, so I'll use all 3 planes of motion. Most of the patients who have these pelvic problems, you'll see some impingement, they're pinching in the front of the hip, so I might use just a flexion component. Use your judgment with the patient. You're going to push your leg down that way. You push me away with like a pound of force. Ready, go, push. Palpate, feel what's happening at the pube. 5 seconds, hold, relax. As she relaxes, next barrier. When does it move? Hold, push down again, and relax. I'm not pushing her hard, we're just pretending she has this. And next barrier. And palpate the pubic tubercle moving as you go through each barrier. So let's go ahead and try that. Make sure to reassess, palpate both pubes with the legs down flat when you're through. So let me just comment on this elevated and depressed pubic bone. Now someone asked in all of their wisdom, well, if the pubic bone has moved, wouldn't the ASIS also move because they're connected? So if they had a depressed pubic bone, wouldn't that typically be found in someone with an anterior rotation of the innominate? You think? Because they're connected. Yeah. So why are we treating them separately? And the actual correction or treatment is the same. So it's interesting, but I'm showing you again, what's in your book comes right out of the literature. This is what's out there, so it's typically taught in muscle energy courses. I'm going from the Fred Mitchell, Phil Griedman, traditional muscle energy, so I'm showing you everything. How often do I actually treat what I think is a depressed left pubic bone or right pubic bone? Less than 5% of the time. I typically see it as a component of an anteriorly rotated pelvis. So for the in-flare, just have your partner on the table, palpate along with me. So go ahead, get a body on the table, feel it as we go, do it as we go. We palpated these earlier. In-flare, for left side, palpate ASIS. Compare that to the midline of the body. Again, sometimes I take a little piece of tape or a string and go up from the center of the sternum, right through the midline, and compare how far away is left or right. If it's an in-flare on the left ASIS is more medial than the right, and the left SI joint is locked. So what do we want to do? We want to bring it more laterally. How are we going to do that? We're going to resist adduction. So if you bring the patient's leg up and out, and this depends again on his, if you look on here, we're resisting mostly adduction. You could add components of external rotation, of flexion, that's really up to you, but it's primarily resisting adduction. Keep the other side down at the ASIS. Bring him out to the barrier, and I'll often kind of lean the leg on me a little bit, let that drop. Find where the barrier is. Okay, and just see when I get to the barrier, now I see I don't have his whole body rolling off the table. Palpate that ASIS. Very gently pull your leg up toward the ceiling into my hand, so resist adduction or adduction internal rotation. Good, relax. Let it stretch and see where that's moving. And as soon as he's pulling out, you feel this moving sideways? Yeah. If I go a lot, you can feel it move a lot. Right. So, but don't go past the barrier. I'm just doing this to show the patient which direction it's moving. Okay, pull your leg up again, hold it, 1, 2, 3, 4, 5, and relax. And gently take up the slack into the new barrier. Okay, so treating that in-flare on the left. Go ahead and try that with your partner, please. If I don't have an extra hand to stabilize, the patient isn't too reliable about feeling something, I'll strap them down. Get the Velcro strap and strap them down. I was mentioning, if you didn't hear, one of the most common places I see in-flares is someone who might have been a passenger or driver in a car and they were impacted on the side that they were sitting. So if the right hip is by the door and they got an impact there, might have an in-flare. Or how about if you have patients who have spastic diplegia and they have that flexion synergy, that flexion internal rotation, they're really tight from the hypertonicity there. What do you typically see? In-flares. So that's an area where the kids with the cerebral palsy, the spastic diplegia, I like to do the correction for the in flare. Start opening up some of those adductors. Start opening up some of those flexors, you see. So that's an area that you might want to look at for correcting some of these dysfunctions. Okay, anyone need more time on the correction? In flare. Okay, let's do an out flare. So out flare on the left. And again, when you're doing this, someone else made a really brilliant comment. You know, patients move and shift on the table. She might decide to lay like this for a while. Didn't that shift her? So just make sure that each time you're checking these things, is she laying straight? So I'm going to give you a little tug. Put your head in the middle. Make sure her arm's in the middle. Make sure she's straight. I'm going to give her a little tug. You'll slide on the table. Let your body slide to keep her straight relative to everything else. Otherwise, you know, who knows if she rolled to scratch something and put herself in a position and it's not a true in flare or out flare. Here we're doing an out flare. So say I palpated, I did my motion testing, the left SI joint is locked. The left ASIS is farther away from the midline than the right. So it's a left out flare. What do we want to do? Flex, adduct, cross. Now you have to be careful if they're impinging here. I like to flex them up a bit if they're impinging. Oh, the front of my hip hurts. It's pinching. Oh, if I drop your leg a little bit, is it still pinching there? No, it went away. Good. So alter the amount of flexion you use. Palpate here. Now you're going to push your leg out into my hand. Feel my hand out here? Push out towards me. Hold it. Count to 5, count to 10, whatever count you decide to use. There's all different things written up in the literature. And relax. And then take up the slack. And sometimes you find they impinge, so you may have other things to do like hip joint mobilizations or other things. Just be aware, you need to look. Many of these things have more than one dysfunction at a time. Push out into my hand. So resisting that abduction and relax. Wait for her to relax and then into the new barrier. Okay, so correcting that left out flare with that hypomobile left SI joint. Go ahead and try that on your partner, please. Okay, let's correct, and I'll do these 2 in a row together and then have you do them as we talk through it, then switch with your partners. So going to do a down slip and up slip correction. Now, to be honest with you, I see a down slip extremely rarely. Again, just as somebody who had some significant trauma went bungee jumping with the string on one leg, created a down slip. So if you're going to bungee jump, make sure 2 legs are in the bungee, okay? Not just one. Or we end up with a down slip, where that whole ilium, that whole innominate on one side is lower. All the landmarks are lower on one side. So that's a down slip. What do we want to do? We want to push it back up. So if you have a down slip, I'll leave the picture up here. There's a down slip here on the left. So I'm going to palpate ischial tube right by the gluteal crease. Where's ischial tube? Now earlier you did your tug test and compression test. Remember that from like hours and hours ago? You're looking to see that shows you for testing up slip and down slip. Now if he has a down slip, I want to use his breathing to start pushing this up. So if you palpate here, go ahead and put your patient in prone. Get the body on the table and palpate, because I want you to feel this as I talk you through it. Now when someone breathes, there's motion through the entire body. You're going to palpate that motion and then accentuate it. So if he's a down slip, his left ischial tube is lower than his right, and his left SI joint is stuck or locked. As he's breathing, if you're very careful to palpate, you can actually feel the ischial tube coming down and going up. As he breathes in, it descends a little. As he breathes out, it ascends slightly. Slightly. You can feel that motion. So as you're doing this, if he's down slipped, you want to cradle that leg. I'm going to apply a little bit of a superiorly directed force through the femur, upward, up slip. And as he breathes in, I'm not going to let the ischial tuberosity descend with the breath. Then as he breathes out, so make your breaths really big. Have him exaggerate the breathing. There's the breathing in, it's descending. There's the breathing out, it's ascending. I'm going to help it on the ascension. Breathe in big. Now I'm resisting as he breathes in, resisting the movement. And as he breathes out, I'm assisting and compressing, trying to slip up, reverse the down slip. So follow with the movement of the breath. Now sometimes people's thumbs get tired. what I recommend, although I haven't seen this in any resource, it's just I like to save my hands. I'll often use my forearm. One thing, patients seem to mind less my forearm on their butt than my fingers on their butt. Okay? So my butt, they don't care what my fingers are on my butt, but anyhow, you get the idea. So thumb, using your forearm, you could get a lot more force, especially if you're using your proximal ulna. Feel the difference? Yeah. Now I can really get up there, and if I take a stance, I have one leg in front of the other, I use my body weight. It's a whole lot easier than killing your thumb. And breathe big. Resist the downward motion. Be a locked entity. As he breathes out, assist the upward motion. 5 reps with deep breaths. Correcting the down slip for the crazy bungee jumper. Now, I'm going to go right into the next one before you switch with your partners, just because it's easier for you. For the upslip correction, I could do this in prone or supine. I find it's more comfortable for most patients with pelvic, sacroiliac issues, etc., to be out of the prone position so they're not hyperextending. Like how many patients have those tight hip flexors, right? So go face up this time. I'm going to follow what we have in your book. Let's remember what that is. So, okay, iliac. This time we're pretending it's an upslip on the left. Everything level in the middle. Here, if it's an upslip on the left, I could use the leg as a lever, distract inferiorly. It works better if you have the hip abducted about 20 degrees, so you could start opening up that SI joint. So, distract. Now, he could do some active muscle energy with me. Make your leg shorter. Pull your leg back toward you. Contract. Quadratus lumborum. Those obliques on the left side, the erectors on the left side, relax. And traction. Long axis traction. Some people do a manipulation. It's not part of muscle energy, but just what some people do. They'll come out, a little internal rotation, abduction, and they'll do a high velocity thrust with distraction, which frankly, if you're in a hurry, in my opinion, works better. But I'm trying to show you the muscle energy. So go ahead and try. There's always a quicker way to do things on occasion. Sometimes those quick things, however, don't carry over if you don't re-educate the muscle reflex. So just personal opinion. Go ahead and try those 2 corrections. Okay, we're good to go. So we actually have someone that had a positive supine long sitting test earlier, and I think you mentioned, was it the right SI joints were locked? Right SI joint? Okay, so on testing today, it was discovered that Joe's right sacroiliac joint was stiff and hypomobile, and it was also discovered that a positive supine long sitting test. So if you measured them, I like to tug them first instead of having them bridge up and down. You know, it's up to you. What can the patient tolerate? That left leg is longer, as we discovered earlier. When he sits up, Joe, come sit up for us. Okay, it becomes more symmetrical. So what do we have? A potential anterior rotation, anterior torsion of the left ilium and a relatively posterior torsion of the right ilium. But since the right side was considered hypomobile, what correction are we doing? The right posterior innominate, or the right posterior rotation. Now, just because I want to follow what's in the book so we don't miss anything, since his right SI joint is locked, I would do the posterior ilium correction first, because that's his greatest dysfunction. So bear with me, I'm going to go slightly out of order from what's here in your book. So just turn, I think it's 2 slides later, posterior ilium. He has the right posterior ilium. Go ahead down flat. Now, right posterior ilium, we have tight hamstrings, and relatively on the other side, perhaps there's tight hip flexors. Typically, I like to correct, just my own thing, I like to correct both sides in a patient and hope they land in the middle. If you did just the posterior right ilium correction and it worked and he was level, there's no reason to treat the other side. If it's not correcting and I did it a few times and I did it a few times, I'm going to go ahead and correct the anterior ilium on the other side and hope it balances out in the middle. So I'm going to palpate and motion test and see if that actually works. Scoot a little bit towards me. Now, we're using the energy of what muscles to correct the posterior rotation. Let's just get the spine so we can look at what that looks like. Posterior rotation. Hamstrings are typically short and tight. So if you don't mind me laying this over by you for a moment. So he's relatively, just exaggerating, he's relatively here. Posterior on the right. What attaches that right ischial tuberosity? Hamstrings. So we could do some of that contract, relax, straight leg raised stretching for the hamstring and see if that works. We already did that this morning. Or we can do a direct muscle energy contraction and see contracting the muscles that oppose the hamstrings, which would be the hip flexors, the hamstrings are hip extensors, contracting their antagonists. Will that correct it? Let's see if it works. Now to contract the hamstrings, what are we going to resist? First of all, what are we doing here? It's a right posterior innominate. Hamstrings are tight. If we wanted to do the contract, relax, post-isometric relaxation, what are we going to do? Push your leg down, relax, stretch them up, right? That's one approach. The more direct approach would be hamstrings are pulling him into a posterior rotation. What muscles oppose the hamstrings? Hip flexors. You're going to hold your leg up. Don't let me pull it down. Hold tight. Hold, hold, hold. So say you hold this for 10 seconds. I've used different amounts of contraction force. I like to start with just something gentle like a pound to see how the patient does. But then if that's not working on some of these, I've had them do more of a contraction force. Say, give me good effort, pulling up, but no pain allowed in your back or anywhere. Just feel those muscles contracting in front of your hip. So pull your knee toward your nose, hold it, hold it, hold it. I don't let it move. Say 10 seconds contraction, relax. Can he do this as a home program? Hey Joe, put your hands on top. You can use two hands if you want. Now I'm going to let go, but hold your leg up like that. Pull your knee up toward your face, hold it for 10 seconds. Don't let it move. He doesn't need me to do this. If you could teach your patient to do some of these contractions on their own, why not? And I'll tell the patient typically like 5 reps to do morning and evening at home until they maintain the correction. Now, how is that for you? Okay, go ahead and do 5 in a row. I did one with you, you did one. You got 3 more to go if we did the math right. What if he was doing these contractions and it did not create symmetry in his pelvis? Would he get it as a home program? No, I wouldn't be wasting his time. What if he's one of those patients who has a limited number of visits and this really helped him? Oh, it made my SI joint pain go away. You know, I felt more even when I was walking. And then he decides after the 4th visit, I don't want to do the $50 copay, I'm not going back to that PT. But he keeps doing this same correction day in and day out. 6 months from now, he breaks his arm, comes back for PT. What am I going to find? The rotation in the opposite direction. So the key is if you're giving a patient an uneven exercise to do at home, it's important to tell him, look, Joe, if for any reason you decide not to come back for physical therapy, you know, you didn't like the $50 copay, you ran out of money, you thought you were doing great, you were fine, stop doing the uneven exercise. I don't care if you follow up with your chiropractor, another physical therapist, somebody, make sure you maintain the symmetry, then you stop the exercise. Don't just keep doing it. I mean, years ago when Mackenzie was really big and everybody's doing backward bending, I had a patient who had come in for a few visits, finished, left therapy, and then some years later she came in for her neck, and her back was like this. I'm still doing that exercise you showed me, serious real person. And that was all she was doing every day, day in and day out, extension. She made herself hyperextended. So you have to let people know, look, we have a program. It's going to be this many visits. We're going to make sure you maintain symmetry. Afterwards, you follow up with your Pilates exercise or whatever your general conditioning is. Okay? What could we do to the other side? If he's posterior on the right, he's relatively anterior on the left. Let's just pretend that it was his left SI joint that was locked. Scoot over to me. So we're correcting the anterior rotation. On the left, we're pretending the left SI joint is hypomobile. Okay, we're going to resist hip extension because what creates the anterior pelvic tilt? Hip flexors. You're going to push your leg down, okay? And I might palpate to see what's going on here and push down. And again, I don't resist by hyperflexing his knee. A lot of people do that. They hurt the knee. Okay, push down, hold it. 10 seconds or so, some people 5 seconds. I find a 10-second gets a better contraction for home, especially home programs, isometrics, get good strength for 7 to 10-second hold, relax. And repeating 3 to 5 reps. Some therapists will have them do both at the same time. And this is not in your book, but just to show you some possibilities. Put both legs up. Now we're correcting the posterior rotation on the right and the anterior rotation on the left. So I'm going to resist the hip flexors on the top of the right leg and the hip extensors on the bottom or the back of the left leg. Squish my arm. I don't have to tell him which way to pull. I just tell him to squish. He'll automatically scissor his legs. Hold it for 10. You okay with that? Good. And some therapists will put a broomstick between the patient's legs and send him home with that. Now I find sometimes that tends to obliterate the popliteal artery on the posterior side leg. So you check and make sure, if it works okay in the clinic, I guess it's okay to do at home, but you don't want to be cutting off circulation on that side of the popliteal artery. So something else he could do. Some patients have them put their foot up against a wall. So you want to correct the anterior rotation on the left. I tell him, at home, put your foot against the wall, push into the wall. So maybe he has 2 broken arms and he can't use his hands. You still want him to do the correction. There's a million ways to do this. They say 20 ways to skin a cat or whatever. But you can do this at different angles. I most commonly do the correction in around that 90 degrees of hip flexion angle. Why? Just personal experience working with patients. I find that more patients are comfortable at that angle. They're not all hyperextended as many are at their hips, and it doesn't make them so sore. Then later maybe I'll do some of the contractions working more into extension to see can they stabilize it. Finally, this is not in this part of the book, but just to show you something else that can be done. You've probably seen that shotgun technique. Now say you got the levels to correct, he's symmetrical. You want him to stabilize. Well, you're thinking, okay, this rotation is rotation of the ilium, ischium, the pubis together. What if we use a stabilizing contraction of the adductors? The adductors attach to the pubes, and if they pull hard together, they might even correct the rotation by itself. So I'll put an arm in between his knees with his knees bent. Let me get an arm in here. And tell him just gradually tighten up, squish my arm, squish together, together, together. Hold it, and might have him hold that for 5 or 10 seconds and relax. Sometimes I'll just, instead of hurting my arm, I'll put a basketball right between his knees. Squeeze that basketball. 10 seconds. So the adductor isometric, when they first do it, often you'll get a loud audible pop because you hear that pubic symphysis gliding back out of its rotated position. So warn the patient, you might hear a loud pop. That's just your joint adjusting itself. You're self-adjusting using your muscles. It is not a manipulation. Okay? And then they could do that technique. I'll have them do the correction, pull up on this side, push down on that side, then take some pillows, or if you have a basketball, put it between your knees, squeeze. Hold it for 10 seconds. I want you to do 5 of those at home, morning and evening, until you hold the correction. So getting those adductors to kick in gives a stabilizing force to help him maintain some of the correction, or even to create the correction. Question? How great of a force? I actually modify this differently for different people. I have not seen it listed that it has to be X number backed up by any literature. For most of the work, a pound of resistance is enough to move stuff. Sometimes if someone's really stiff and really chronic, I might tell them, give me good effort but no pain. So I have them working a little hard, but if they're saying, well, my back hurts when I squeeze too hard with my knees, and then you're squeezing too hard. So I'll often use the term good effort but no pain, or just give me a pound. If I could correct it in a pound, it's probably not some chronic fibrosed condition. If it's not correcting right away, give me a little more effort. Let's see what happens with that. So judge it by the patient and their response. I've seen some people in their muscle energy books, if you don't use exactly 15 pounds, it's not going to work. I've seen other ones that say a couple ounces and others say a pound. Who's right? I go by what the patient tolerates, what's actually changing on the patient. And if you start with light resistance, you're not likely to hurt anybody. If you start the way I learned in PT school, I'm really contract, make them work, make that bone move, you're likely to strain somebody. And now you've done them a disservice. So let's go ahead and practice that.